Oye, ¿tú buenas ondas de aquí al infierno de arriba? Y tienes un pie ahí. Sí, sí,
Am I audible?
Okay, okay. Ma'am, good afternoon, madam. Good evening, madam. I am Dr. Anand, CGP State Secretary, ma'am, here online.
Good evening, sir.
Good evening, ma'am. So we are just waiting for our chief guests. Three of them are joining now, madam. If they join us in a minute, we'll start the meeting, ma'am. No problem, madam. Huh? So thank you, ma'am. Waiting for them. Thank you.
Anand sir, Sridhar sir வந்துட்டாருங்களாங்க சார்?
ஸ்ரீதர் சார் லாகின் பண்றாரு செந்தில். இவரும் செங்குட்டுவன் சாரும் டிராவல்ல இருக்காரு உங்களுக்கு. நிப்பாட்டி லாகின் பண்ணிடுறேன். 1 minute எல்லாரும் உள்ள வந்துருட்டாங்க. வந்தோடனே வில் ஜஸ்ட் ஸ்டார்ட்.
எஸ் சார்.
செந்தில் மதன் லாகின் பண்ணிட்டாரா?
வந்துட்டாருங்க சார், இருக்காரு.
லாகின் பண்ணிட்டாங்க.
ஆமா, ஓகே ஓகே ஓகே, தேங்க்யூ.
Anand sir, Cgpcon sir வந்துட்டாருங்க சார். We will start the program, sir.
Senthil, can we start? Senthil? Senthil, கேக்குதுங்களா?
Yeah, I think just now we can start.
Yes, sir. Yes. A very good afternoon to all. I welcome you for the second day of the Tamil Nadu State CGP conference today. Yesterday was the first day. We are having it on for the 5 days from yesterday. So yesterday was a session on pediatrics and adult vaccinations and animal bites. Today's section is a session on exclusively to OGs, not OGs, and obstetrics and fetal medicine both together. So on behalf of IMA Tamil Nadu CGP, I would like to welcome our President-elect Dr. Sengattuvan sir, Dr. Sridhar sir, President-elect Dr. Sridhar sir, and our State Finance Secretary Dr. Gauri Shankar sir, and our State CGP Chairman Dr. Senthil, and our State Office Bearer Joint Secretary of CGP Dr. Madan. Both are radiologists, so they are a role in this meeting, I hope. So first I request Dr. Madan sir to start with the IMA parent physician pair. Madan sir. Dr. Madan.
Sengattuvan sir is trying to join, sir. He'll reconnect again. We will start the
Okay.
meanwhile we will start. The Madan sir.
Madan sir, are you online?
Sir, நீங்க proceed பண்ணிடுங்க sir.
With the physician pair, yeah. Okay, IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every creed and lure. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and to realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you. Now, I request our IMA CGP Chairman Dr. Senthil to give his welcome address. Dr. Senthil.
Yeah. Good evening all. I welcome you all for the day 2 program of the Tamil Nadu Cgpcon 24. So we have all topics related to obstetrics and how a general practitioner who is encountering a case, how to deal with it, and also radiology imaging point of view, few points will be shared, and also we have fetal medicine. So we will start with this session. I request Dr. Sengattuvan sir to give his felicitations. President-elect.
Good evening to everybody. Thanks for the opportunity given. Really, our CGP is doing marvelous job. It's commendable, very commendable. That under the leadership of Dr. Choklegam is doing as a program of the conventional CGP program. 5 days program is already we have started from during my period. This time also they are doing the wonderful job, and this is appreciable and to be appreciated every time. So this workshop will be very useful to the delegates, and I also welcome the speakers this day. Thank you for the opportunity given. Thank you, Senthil Kumar and Anand Choklegam. Over to Anand Choklegam.
Thank you, sir.
Thank you for your kind words, sir. So now I request Dr. Sridhar, who was also previously holding the chairman of CGP, and he did a very commendable job during his period, as like Sengattuvan sir was saying during his period. So I request Sridhar sir to give his words of felicitation. Sridhar sir.
Good afternoon, everybody. It's the President-elect Sengattuvan sir, Finance Secretary Gauri, Chairman Sendil and Secretary Anand. It is always a great pleasure attending a CGP meeting. It's like homecoming. As you said, I had enjoyed thoroughly my tenure as CGP faculty secretary just before I became the state secretary. I think now you have the added advantage of a Zoom through which so many can join and attend these meetings and enrich their knowledge. And it's a nice, really nice idea that each day you have selected a topic so that
எப்படி இந்த வைஃபை
things
வந்து
can
இது பண்றது
discuss,
கனெக்ட் பண்றது
things can be discussed in detail. So this is a very good move, and IMA CGP under the guidance of the IMA TNSB led by Abul and Karthik and Gauri, you are doing a commendable job. I wish you all the best for the rest of the 3 days also. Hoping to meet you all guys in person at Pollachi on Saturday. Thank you, and over to Anand.
Thank you, sir. Very kind of you, sir. We'll meet in the validated function in the Pollachi branch on Saturday, sir. Thank you for your kind
Yes, sir.
words,
Yes,
sir.
sir.
And
Okay,
now I
yeah.
request our State Finance Secretary, Dr. Gauri Shankar, to give his words of felicitation. Dr. Gauri Shankar.
Yes, thank you, Anand sir, Dr. Senthil sir, and all the office bearers of CGP, Madan sir, chairman, secretary, joint secretaries, and council members. All are doing a wonderful job. So actually, there is a great kind of little fight between CGP, AMS, and also on academic committee that who is doing better. It's a welcome fight with us. We are enjoying this kind of this thing from all the wings and schemes. So they are doing a very exceptional job. So it's a very good move for from IMA that all people are indulging themselves in activities, various activities. So and they have rightly chosen different topics. Almost all topics are covered every day. Almost all topics are covered. So you're doing a wonderful job. So please finish it off in a wonderful fashion. Thank you everyone for the opportunity. All the best to all the people who are involved in this. Thank you very much.
Thank you, Dr. Gauri Shankar, for your kind words of appreciation. Now we'll move on to the session for the day of today, obstetrics and fetal medicine. There are 4 main topics today to be covered. The first one will be by Dr. Manikandan, aneuploidy screening basics and beyond. Second topic will be by Dr. Devarajan, role of obstetrics Doppler in screening and management of pre-eclampsia and IUGR. The third one will be ultrasound evaluation of early pregnancy bleeding by Dr. Lakshmi Ravi Selvaraj. And the fourth topic will be ultrasound assessment in abnormalities of liquor volume, placenta and umbilical cord by Dr. Adinarayanan Makham. So I now hand over the scenario of today to our moderator of the day, Dr. Aishwarya M. Raji, who is going to moderate all these sessions on obstetrics and fetal medicine. It's over to you, Madam, Dr. Aishwarya, Madam. Ma'am, are you online? Dr. Aishwarya, ma'am.
She needs to unmute.
Madam, you can unmute, madam.
Good evening.
Okay.
Good evening, everyone.
Yes,
Good
yes, ma'am.
evening,
Yes,
sir.
ma'am. Now the scene is yours, madam. We can take over, ma'am.
Thank you. Thank you so much. Today we have a very eminent list of speakers who are stalwarts in the field of fetal medicine. So each and everyone have such high practices in the field of fetal medicine. First, we have the talk on aneuploidy, the basics and beyond. We have Dr. K. Manikandan. He is MD, DNB, MRCOG, and PDF postdoctoral fellowship in fetal medicine from Mediscans, Chennai. He's a former associate professor of obstetrics and gynecology from JIPMA, research fellow in fetal medicine, King's College Hospital, FMF UK, special training under the National Teacher Training Course for Teachers of Higher Education, JIPMA, statistics and epidemiology training from Harvard, quantitative methods in clinical and public health. Sir is a lead consultant fetal therapy, the Fetal Clinic Pondicherry and KMCH Coimbatore, KEM Pune. He's a visiting professor there. He's also a visiting professor of perinatology field in the Pondicherry Institute of Medical Sciences. Special interest is preeclampsia prevention and teaching evidence-informed practice. The ongoing project is on fetal growth chart. On to you, sir. his topic will be on aneuploidy screening, basics and beyond, the implications in clinical practice, which each and every obstetrician has a report in their hand, and they should know how to apply, what to apply, when to apply. On to you, sir.
Thank you very much. First of all, I thank you all the delegates who have joined in such huge numbers for this session. Also, it reflects the work that has been going on from the CGP team. And thank you, IMA leadership, CGP leadership, for bringing all this together. Aneuploidy screening is a very important topic that most middle-aged practitioners should get updated with, because this was not there when we started our practice. And today, the expectation from the pregnant mother and her family is so high that when we omit the screening, and then by the rule of nature, 1 out of 700 births would be Down syndrome, and then the problem rises for the practitioner. So I have sort of modified the presentation to suit the mixed audience here, but feel free to ask any questions if you have at the end of the presentation. All right. For those who would like to go in depth into how aneuploidy screening works in our setup, I suggest this article, which I published in 2017. We have analyzed the outcomes and the risk distribution in about 27,000 pregnancies. And there is a commentary or a discussion on how this would be useful in our system in this article from 2017. Let's go to the topic. Basically, intellectual disability in childhood can be either due to a genetic cause or an environmental cause, the former being more common. Among genetic causes, chromosomal abnormalities are more common than single gene abnormalities. So we need to differentiate these two. In chromosomal abnormalities, the most common one that we see in everyday practice is a Down syndrome, which is trisomy or 3 copies of chromosome 21. This is an error in nature and need not come in consanguinity, need not have family history, need not be restricted only to older women, but can happen in any women at the rate of 1 out of 700 in the general population. Among the single gene disorders, the most common is Fragile X, but this is far less common than the Down syndrome. Now, let's take, for example, the district of Tanjavur, which has an annual birth of about 40,000 deliveries per year. Out of this 40,000 deliveries, at the time when we do the aneuploidy screening, which is 12 weeks in the correct setup, there would be about 82 fetuses that would have Down syndrome. Now, when we introduce a screening test, the best screening test today is what we call as the combined first trimester screening. When we introduce a screening test, the purpose of the screening test is to segregate this 40,000 fetuses, the general overall population, into, hold on, let me just, into 2 categories. A smaller group, which will contain majority of the Down syndrome babies, and a much larger group in which Down syndrome will be few and far placed. As you can see here, the standard screening test will identify 2,000 women out of this 40,000 overall population, pregnant population, as high risk. And within this 2,000 women, about 74 out of the 82 Down syndrome will be captured. The remaining 8 Down syndrome fetuses would have been classified under the screen negative group, which is very vast, that is 38,000 women. Now let's focus on this screen positive group. Out of this 2,000 women who have been classified as screen positive, about 74 of the original 82 fetuses that are being Down syndrome inside the womb, which we don't know who it is Downs and who is euploid, will be present among the 2000. Now, by nature, 40 would miscarry, and based on previous experience, about 400 women will withdraw from the test. That is, they would undergo screening and then they will not come for the diagnostic test. But about 1,600 women, or exact 1,560 women, will undergo further tests in the form of a diagnostic test in order to identify and find out these 74 fetuses. So the aneuploidy screening structure itself is like this. You test everybody for aneuploidy screening, that is, give a basic test, out of which some are selected as screen positive. And to all of those screen positive, we then advise the diagnostic test. The diagnostic tests are CVS, chorionic villus sampling, and amniocentesis. There are some situations which I'll discuss later, where we can use a very sensitive screening test to exclude Down syndrome rather than give a confirmatory test to all. Now, let's look at the group where there is screen negative. This is a very large group, 38,000 women, and in which about 8 fetuses would be Down syndrome fetuses. They would have been classified by the screening test as screen negative. So in this group, you can reassure them, stating that the chance for Down syndrome in your pregnancy is very low. You can come back for the 5th month scan. Now, what will happen to these 8 fetuses? By the natural history, 2 of them will ultimately end up in a fetal demise. In 2 of them, during the 5th month scan, there will be multiple soft markers. Soft markers are non-defects, but variants in the anatomy picked up by ultrasound. For example, echogenic focus in the heart, an echogenic bowel, mild hydronephrosis, relatively short femur, right aberrant subclavian artery, an increase in thickness of the skin behind the neck or the nuchal fold thickness, and the ventricles being borderline, the cerebral ventricles, the lateral ventricles being borderline, that is 10 mm, 11 mm. So these are all soft markers. So in 2 of these fetuses, during the 5th month scan, when we do a thorough checkup, we will pick up multiple soft markers, and then they will be tested with an invasive testing. And in 2 of them, among the 8 which we are talking, 2 of them will show major defects such as heart defect, an intestinal defect, and other things. So then also, when we see them, we will advise an amniocentesis, and ultimately you will pick them up as Down syndrome in the 2nd trimester. So the remaining 2 would be live born, and this 2 represents the missed cases of Down syndrome in the entire population. So when we started screening in the 40,000 pregnant population, there were 82 fetuses, of which after the entire screening process, which is the initial screening test and invasive test, followed by the 5th month scan and its action, 2 of them will be born. So the chance of birth of Down syndrome baby, when everybody follows the correct protocol by this testing strategy, is very low, 2 out of 40,000. All right, so what is the screening test? The current standard screening test is what we call as combined screening test. In combined screening test, we combine a 1st trimester nuchal translucency, that is a dark band behind the fetal neck when the fetus is in the 1st trimester, that is between 11 weeks and 14 weeks, or the length of the fetus is between 45 mm and 84 mm. In this time period, all babies will have fluid behind their neck, and this fluid is measurable by ultrasound. When we measure it using a proper technique, it will give us a factor, a risk factor. And this risk factor is then combined with the blood test that is drawn from the mother is processed to measure the levels of two hormones, free beta HCG, that is HCG in its free form, and pregnancy-associated plasma protein A or PAP-A. Now, this measurements of these hormones also gives us a risk factor. We combine both risk factors, and based on the maternal age, the FMF Fetal Medicine Foundation UK approved algorithms will correctly calculate the individual's chance. So that is given as the final risk or adjusted risk. So here risk represents the probability that that pregnant lady is carrying a fetus with Down syndrome. So once we get the final adjusted risk, then we take action based on whether it is screen positive or screen negative. Now, a word about why the ultrasound should be done perfectly. You have here 3 images. When we get a report of first trimester NT scan, it's important that we look at the image and see if it has been taken properly. It's very important that the ultrasound section goes through the mid-sagittal plane of the fetal head and should be fully magnified so that the head occupies everything. A little bit of thorax should be seen. The baby's neck is in a neutral position as seen here, for which you can see some fluid between the chin and the chest. And then the caliper is placed correctly. So every detail need not be looked upon for the non-specialist. But you can create a pattern of this image in your mind. If it's a properly zoomed and an image that shows a face like this, it's going to be accurate. In contrast, when you see images on the right side, where it's not zoomed very far away, you don't see where the nuchal is present in the top image. And in the other image, the entire baby is seen and somewhat a non-mid-sagittal plane is being taken. So these are potential pitfalls and likely will end up in a big problem when the baby, and if at all the baby turns out to be Down syndrome at birth. All these will be questions. So we need to be very careful at the beginning itself. Now, what are all the blood tests that can be done? This is also important because in the market, because commercial labs come up every day with newer reagents and platforms, it's easy to get distracted. As per the FMF guidelines, there are only 3 FMF approved platforms: BRAMS, PerkinElmer, and Roche. Under these, there are 2 or 3 machines that are being approved, and these platforms only have to be used. The lab should also maintain correct calibration and quality checking in a periodic manner. So it's very important that you talk to the lab and ask them, are you using the correct platform that is approved by FMF? Are you using the correct software to calculate the risk provided by the FMF? So only these things will ensure that we are safe at the end of the pregnancy. We can defend ourselves even if the test goes wrong. So how does the screening program work out? It's a opt-out program. Firstly, all women are counseled. They are offered Down syndrome, and currently we also offer pre-eclampsia screening in the first trimester. A thorough pre-test counseling is provided, whereby either by visual tools or by person to person, we explain what is meant by Down syndrome, why we are screening, and what is the result that you can get out of the screening. Also about pre-eclampsia. Now, at the end of this counseling, few women will still opt out of screening. We accept that, but we document that in the case sheet. If possible, we also get the signature. In majority, when you do a proper counseling, the women accepts screening. Now, once they accept the screening, the first step is a detailed fetal evaluation by an expert ultrasound at the first trimester. The length of the fetus will be about 5 or 6 centimeters only. So it requires a lot of patience and experience to perform this detailed fetal evaluation. At the end of the fetal evaluation, we might identify a major fetal defect in about 1% of all fetuses. We might find the fluid behind the baby's neck, that is the nuchal translucency, being more than 3.5 mm in about 1% of fetuses. And in all these cases, whether there is a fetal defect or the NT is large, we advise direct testing without going through the screening process. The direct testing may be CVS or amniocentesis, and what we test in the direct testing is requires a lot of discussion. So let's say that we do a direct testing and do a fetal sampling in these two situations, no going through the screening process. Now, these are not there during the, at the end of the evaluation, everything is fine for the fetus, but the maternal age is more than 45 years, let's say by spontaneous conception, which is uncommon, but by IVF conception, which is possible and common these days, then we don't go through the combined screening test. We offer them NIPT. I will explain this test a bit later, but this is what we offer when the mother's age is 45 years or more and she has conceived using her own gametes. Now, younger women, ultrasound is normal, but we see that the gestational age is more than 14 weeks or the CRL is more than 84 millimeters, then they are not eligible for a combined screening test. We may have to bring them back in about 10 days to do a quadruple screening test. In current practice, the only indication for quadruple screening test is this situation. Now, when none of these criteria are met, the woman is eligible for the second step, which is the combined first trimester screening. In the combined first trimester screening, we take maternal age, we take the history-based risk factors for preeclampsia. We get all these things through history. We measure the maternal blood pressure in a very standardized way using electronic apparatus on both arms. Mean uterine artery resistance in terms of pulsatility index is measured. This is for preeclampsia screening. And then in the ultrasound, we measure the nuchal translucency, the nasal bone, the blood flow resistance in the ductus venosus, and flow across tricuspid valve. Now, anything other than the NT I have mentioned here, that is NB, DV, TR, nasal bone, ductus venosus, tricuspid regurgitation, these are all optional. When you do these, your detection rate increases and your false positive decreases. But the basic minimum is NT and biochemistry. What do we do in the biochemistry? We take the mother's blood, we spin it, and from the serum, we measure free beta HCG, PAPE. If you are also offering pre-eclampsia screening, we measure the placental growth factor or PLGF. All right. Now, once the step 2, that is the combined first trimester screening, is done, we will focus on the trisomy 21 aspect. We will get a result, and this result represents what we call as the final risk or adjusted risk. This number represents the probability for that woman, for that individual woman, to have a Down syndrome fetus. When this number comes as less than 1 in 250, which means, let's say, 1 in 500, 1 in 1,000, 1 in 10,000, 1 in 20,000. So these are all less than 1 in 250 probability. Then we classify that pregnancy as screen negative, and then we can reassure, ask them to come back for the target scan. So remember, at the target scan, we will still be looking for soft markers and defects, but at this point, we can reassure them. Now, if the risk comes back as, the final risk comes back as more than 1 in 250, that is 1 in 200, 1 in 100, 1 in 150, then they are classified as screen positive. Now, in screen positive, a further step is required, and this step is to either diagnose if it is Down syndrome or not, or we can exclude Down syndrome. So both are okay. So I say this because there are two ways to approach a screen positive case. Now, we look at the actual number, not just whether she is screen positive or not. we look at the actual number to decide which step we will use in step 3. If the final risk is less than 1 in 20, that is, it is 1 in 50, 1 in 100, 1 in 150, 1 in 200. So these are all less than 1 in 20 probability. Then many of them will get the new test called NIPT. Some of them will still get the ultimate test, the diagnostic test, invasive test, direct test called CVS or amnio. When the final risk is worse than, more than 1 in 20, say for example 1 in 10, 1 in 5, 1 in 2, then all of them will get direct testing or CVS or amnio. Now, when we do the NIPT, the result will come as high risk or low risk. It is not a diagnostic test. Therefore, it will not come as detected, undetected. It will come as high risk or low risk for Down syndrome. When it comes as high risk, again, we have to go to direct testing. And therefore, this point needs to be discussed before we order a NIPT. When it comes as low risk or when the direct testing comes back as normal, then we send them back to routine care, call them back at 22 weeks to do the target scan for structural defect. So far, we have been only screening and talking about Down syndrome and chromosomal defects. When the direct testing shows abnormal, then that couple should receive a detailed genetic counseling, which will tell about the features of Down syndrome, what to expect if they continue the pregnancy, and what happens in the next pregnancy, how to manage and mitigate the recurrence risk. Now, I was briefly mentioning about a new test called NIPT. This is a very sophisticated, costly, advanced screening test. What we do is we collect the mother's blood. In the mother's blood, we have free DNA, that is DNA that is not bound inside a cell. So this free DNA is present and has origins from both the mother and the fetus. The fetus directly doesn't give, the placenta will give this free DNA. Now, the entire free DNA is collected, is amplified using PCR technology, and then sorted into various chromosomes. Now, from the sorting itself, we will be able to tell that chromosome 1 and 2 will be the major portion of the free DNA fragments, and chromosome 21 should constitute only about 1.5% of the whole DNA fragments. When this pattern is maintained, we can very easily say or very confidently say that T21, the fetus being Down syndrome, is very low chance. So we can reassure the parents. Again, this whole test is dependent on a lot of calculation and bioinformatics. So it's not like a direct test. So we need to know the context. We need to have the ultrasound as a backup, and we need to be very confident in the lab that the lab is a reliable lab. So if the NIPT comes back as high risk, then we should not terminate the pregnancy or offer termination thinking it's a Down syndrome fetus. In my own practice, I have saved a couple of times a baby who has been labeled as Down syndrome by a lab. So what we do is we tell them that the chance is high, but there is a chance it may be false. Then we do an invasive testing. So that is because once we terminate, it's irreversible. Now, when the report comes as low risk, the chance that it is going to be Down syndrome is less than 1 in a lakh or 1 in 10 lakh. So we reassure them and routine follow-up can be given. A point to note here is we will not offer NIPT when ultrasound shows a structural defect. Then we should not offer NIPT. In about 4% of the cases, and it depends on the lab, it can be 1 to 5%. When you send the NIPT, the lab may say we do not have sufficient fraction from the fetal origin, and therefore we are unable to give a result whether low risk or high risk. And in these cases, it requires then a specialized approach. We may repeat, but we should keep in mind what was the original probability of abnormality. So then that becomes a different management, which I don't want to discuss in this short frame. Let's move to the new terminology that has been surfacing from some commercial labs, and it is called intermediate risk. In my clinic, we do not give cognizance to this category at all, because this category was introduced as a model to see how newer ultrasound markers such as NT, NB, and NB, DV, and TR were going to modify the risk calculation, especially sensitivity and specificity by the FMF. So I wrote to a consultant, Gauri Shankar sir, you all know, who has been a FMF trained student and has been working in UK for some time. So I wrote to him asking that, do you really have intermediate risk in the NHS? He said, no, it's not practiced in the NHS. And only FMF has used this as a model, not as a practice. So I also wrote to a doctor, fetal medicine doctor of Indian origin in practicing in the US, and asked if they also have a category called intermediate risk, and she replied in the negative. All right. So what does this intermediate mean, and how is it going to affect our practice, if at all you give cognizance? It's a very confusing thing for both the practitioner and for the patient, because once we identify a separate group as intermediate, which nobody knows how to define. Currently, labs give between 1 in 250 and 1 in 1000 final risk as intermediate, and there is no basis for this. In that case, what happens? We have an additional 6,000 women who would be under some kind of anxiety or stress, would be highlighted as though there is a problem. And of the 6,000, only 4 would be having a true problem. So all the 6,000 would then be put under the stress or would have to undergo further testing in order to find that 4. Let us see some situations of intermediate risk and see how we can tackle them. So this is a 37-year-old third gravida. She conceived on her own. Look at the starting risk. So let me just activate the laser. Okay. So look at the starting risk. The starting risk is 1 in 289. That is because she's already 37-year-old. Now, having gone through the screening test, she has become 1 in 335, which is very well lower than her starting risk. Now, we can always reassure this, but before we reassure such a patient, I want you all to look at the NT image. The NT image, as it is seen here, if it is taken properly, then you can very well rely on this and say your chance is very low. You please come back for the target scan, at which time we will perform, in addition to looking at the defects, we will also look at the genetic sonogram. And if the genetic sonogram is normal, genetic sonogram means we check for all the 9 soft markers which I mentioned before. And if it is normal, then we say your chance is very low, you can go home. Now look at this scenario. Here is a 37 also, third gravida again, spontaneous again. Now the lab itself has given a risk of 1 in 730 here on the right side, 1 in 730 as the final risk for Down syndrome at the end of the first semester screening. And the lab itself has mentioned it as intermediate risk. This is something we should dissuade them from doing. Now, so the first step is to look at the NT image, as I told before. This is one of the NT images that I had shown previously also. This is totally unreliable. We don't know if the NT was taken properly or not, whether it is large and increased or decreased. So this is a substandard NT. So when you get intermediate risk or so-called borderline risk, and if the NT was taken substandard, then the next step is to do a detailed ultrasound. A detailed ultrasound, if it doesn't show any defect, if it doesn't show any soft marker, both are important, then in this scenario, you can offer NIPT. If the NIPT comes low risk, leave them alone. If it comes high risk, or if the detailed ultrasound shows some defects or some markers, then you should go for an amnio to be on the safer side. Now, let's look at this case. She is a 24-year-old primary gravida. She is 12 weeks, 3 days. The NT measured 3.2. Remember, it is less than the 3.5 cutoff that we discussed before. And the remaining markers are normal. The final risk for this lady, from 1 in 1000, it has come to 1 in 340. That means the risk has increased, but it did not reach the screen positive threshold. Now, in this case, if you are recognizing something as an intermediate risk, how to go about. This is a standardized NT taken very well. But look at the NT value. The NT value is more than the 95th centile, as you can see here, but less than the 99th centile. It has to be less than 99th centile, then only we will take the combined test into account. So standard NT, but it's an increased NT. Then what happened? Once again, do a detailed ultrasound. And if the ultrasound does not show any defect or marker, go for NIPT. But it shows some defects or some markers, then amnio is the safer tool. All right. So I personally prefer that we do the first trimester screening very well, include at least NB. Therefore, we need not recognize this intermediate risk at all, and also inform the labs not to report like that and cause a lot of confusion. But in case or till that is going to happen, if you are going to recognize intermediate risk, then the first step is compare with the background risk. A very old advanced maternal age has become intermediate is actually better. The risk has only lowered. Audit the NT image, whether the NT has been taken per standard as I had shown you before. And then a detailed fetal evaluation should be done when you are seeing. It might be in the first trimester itself. It could be in early in the second trimester, but get an expert opinion on the fetal evaluation. If the fetus does not show defect, the NT is normal and has been taken per standard, and the risk has only improved, not decreased, then you can reassure after a genetic sonogram. But if the NT is substandard or is taken standard but is increased the NT, then if there are no defects, offer NIPT. If there are defects or soft finding on the ultrasound, then go for amnio. Therefore, I would suggest that we push for a standard NT in every single case and include at least the NB in order to bypass this trap of intermediate risk. And don't recognize it if you're already using NT and NB. Blanket NIPT for intermediate category should be avoided. So thank you very much. I will stop here. I hope I have given you an overview of the aneuploidy screening and also some complexity that is creeping up into this nowadays. So if you have any questions, I'm happy to address them. Thank you.
Thank you, Manikandan sir. That was an excellent presentation. It's an eye-opening for many of the new doctors who are looking for the aneuploidy screening. It is simplified in such a manner that every doctor understands the purpose of doing the aneuploidy screening. Thank you so much, sir. Thank you. Don't think there are any questions posted here. There are questions posted later.
There's a question, Madan.
There is a question now. Now is the question.
Aneuploidy occurrence in ozone and eclipse is a question by one Dr. Sundaramurthy.
Dr. Sundaramurthy, yes.
Thank you, sir. In eclipse, we do not have any scientific reason for aneuploidy, and ozone exposure probable, but has not been studied in papers, sir. As of today, the main determinants for Down syndrome or maternal age due to error in meiotic disjunction, either in meiosis 1 or in meiosis 2, or the mother or the father already having a balanced translocation. Thank you.
There are a few questions from the obstetrician, sir. So yes, there is this couple who's coming from an IT department in Coimbatore. They come and tell me at 12 to 13 weeks that, ma'am, I don't want this first trimester screening of double marker and all. I want to go for an NIPT directly because I have read somewhere that it has a very high sensitivity. So why can't I go for a non-invasive prenatal testing where I have a 99% sensitivity according to the internet? So what would I want to say to them, sir? What would that is the obstetrician's question.
Correct. Yes. I think when now it has become a consumerism, isn't it? So therefore, when the consumer comes and asks, we document that. We should be in a position to explain the principle behind NIPT and that it has a good sensitivity, but in about 4% of the cases, your blood may not be giving enough fetal fraction for the lab to call. If you're understanding all these things, that is, call rate is 95%, no call rate is 5%. If you're able to understand that, you please take it.
But they cannot
uh,
escape an NT, isn't it? NT scan is mandatory. The
Absolutely.
the 12-week scan is mandatory. They are saying, I don't
Absolutely.
want to scan anything. I just want to make sure my baby is not Down syndrome. So I want an
Okay.
NIPT correctly.
I thought the dual marker they didn't want, but a thorough evaluation of the fetal anatomy, including NT, is a must before we even open up what kind of screening is available for them. Yes, madam.
Yes, sir. So there is another couple whose first trimester screening is 1 in 10,000. Then after it is a properly done NT at a very good center. And now they come at 22 weeks with an anomaly scan report saying it is an unossified or a hyperplastic nasal bone with another soft marker. They've just written in the scan report saying there is also an echogenic intracardiac foci. So now what do I have to tell this patient? Now I've told her, no, there is absolutely no risk for Down syndrome in this baby. At 12 weeks, your baby is all right. And now there is this report which they come with, ma'am, what does this mean? So they're coming and asking that question.
Correct. So just we'll go back one step, and at the end of the first trimester screening report, the post-test counseling should be what I had told. The chance for Down syndrome is very low in your pregnancy. Go home happily, come back for the 5th month scan. So we should always say very low, low, never to say no risk. Now, in this case, in this particular case, the best step forward is to do an amniocentesis.
So do we have to re-risk them? That is, do we have to recalculate their risk at that point of time? Or just because it is a hyperplastic nasal bone, directly we are going to tell them you have to undergo an amniocentesis?
Correct. In this case, you had mentioned there were 2 soft markers. In addition to the NB, there was one more soft marker. So automatically, when there are 2 soft markers, we tend to do an invasive test, a direct test.
Okay. So if it is only a echogenic intracardiac foci or a short FL, we will not be advising them with a very high negative report in the first time screening, that is 1 in 10,000 or a 1 in 1 lakh, let us say. Then we can reassure them at that point, isn't it? 22 weeks.
Absolutely, absolutely, yes. So when there are minor soft markers, for example, ventriculomegaly, nuchal fold, right subclavian artery, and nasal bone. These are all major soft markers. But if you have minor soft markers on the background of a very good NT scan and a very low risk in the first trimester, you can absolutely reassure them.
Okay, sir. So at the age of 43 years, if the lady comes to us with her first pregnancy at 43 years, what is the protocol for her, sir? What do we have to
Same,
advise?
madam. In our clinic, we include all the ultrasound markers and we do the combined screening only up to 45 age. Now, as part of the pre-test counseling, we will always be telling the option of NIPT also as a direct thing. But in majority of the times, the women will take combined screening. And if it comes low, we will reassure them. If it comes high or borderline, we will highlight it. It has come like that. We explain them the numbers.
Yes.
You can go for a
that is
combined
all the
screening.
questions
If
that we
your
have received.
fetal medicine team is reliable, you should go for a combined screening only. Combined screening, let me finish
And
with
with
this.
the report, most likely.
Yeah.
Okay.
The combined screening test, when it is low risk, less than 1 in 1,000, the negative predictive value, which is important for the mother, is as good as an NIPT. So this point we should all remember. We need not panic too much.
That's all, sir. That's all the question there in the question box. If there's anything more for Dr. Manikandan, thank you so much, sir, for such an elaborate talk and your clinical aspect that you have enlightened us with for aneuploidy screening, because it has evolved over the past 10 years. every 2 years the protocol has been changing, and they've been updating both in the West as well as how much we can put that in our clinical practice is also a matter. Thank you so much.
Thank you. Thank you very much.
Thank you, sir. Now, next we go on to the next topic by Dr. P. Devarajan, MBBS, MD Radio Diagnosis. He's a fetal and interventional radiologist at Netra Scans and Fetal Medicine Center and Genetic Clinic, Tirupur, Tamil Nadu. Member of National Academic Committee and Course Director for FTS Samraksham IRIA. Academic qualifications, he is MBBS from Coimbatore Medical College and MD Radio Diagnosis from Bernard Institute of Radiology. Fetal medicine training at Sonoscan Coimbatore in the year 2015. He's got various publications in his name, and he's got a research article on routine third trimester Doppler in fetuses with estimated fetal weight of 10 to 58 centiles in Indian Journal of Fetal Radiology in Jan 2020. Sir is going to enlighten us about the role of obstetric Doppler in screening and management of preeclampsia and FGR. Over to you, sir.
Thank you. Thank you, the CGP wing of IME through IME Tamil Nadu, and particularly Dr. Sendil Kumar, who is interested in, for first time, including obstetrics and fetal medicine in the academics of annual conference of CGP. Thank you, the CGP wing team, office bearers, and IMA. Let me go to session. Am I audible, madam?
Yes, sir, you are.
Okay, yes. And my screen is visible?
Yes, sir.
Okay, thank you. Sorry, I am just role of obstetric Doppler in screening and management of preeclampsia and IUGR. Yeah. Before going into the our presentation, we will look at the Indian scenario of pregnancies. So we have large number of pregnancies, about 28 million pregnancies annually, approximately, and the 26 million live births. With also we have large number of maternal deaths, 67,000 maternal deaths annually, and 1 million neonatal deaths, and 7.5 lakhs of perinatal. So IMR is about 42 per thousand India. So just a minute, I have some issue. Yes. Okay. So can you see the slide change there? Actually, slide is not changing to me.
So we are seeing the slide of high incidence of low birth weight in India, sir.
Just a minute. Just a minute. I need to stop sharing and reshare again because it's not moving to me. Just a minute. For 2 minutes, I have to rejoin again because some issue in connectivity. Okay. So let me connect it within 2 minutes. Sir. ஒரே நிமிஷம் நானே சிஸ்டம் மாத்திட்டு இருக்கேன் அதே கொஞ்சம் ஸ்டக் ஆகுது ஒரே நிமிஷம் 2 minutes ஓகே
No problem there. I'll suggest.
Okay, sir. Sure.
Yes, sir.
Just a minute.
In the meantime, I'll just tell about Dr. Devarajan sir and the IRA's Samrakshan programs.
Yes.
During the time when he's connecting, the IRA
Yes, Mohan.
Samrakshan program is a national program that aims to reduce the perinatal mortality in India through a systematic and phased approach that will train and guide all the radiologists in India to screen using the ultrasound and color Doppler at 3rd month and 8th month to identify the risk of pregnancies for preeclampsia and fetal growth in India. So Dr. Rijo Matthew is the post coordinator and our Dr. Devarajan is one of the national coordinator for the IRA Samrakshan, which has dramatically changed lives in many distant parts of India where preeclampsia rate has come down with the proper screening methods available by given by the radiologists and sonologists over there. So this is a short introduction about the IRA Samrakshan. I wanted to highlight, and Dr. Devarajan sir is one of the coordinators for the IRA Samrakshan. Thereon, sir, if it is getting delayed, can we go to the next talk so that in the meantime you can be ready with your talk?
Yes, sir. We can do like that, sir. We can start with the next speaker.
Yeah, yes, sir.
Then we can come back
So that
again.
Theron, sir, will be ready by that time.
Ma'am, Aishwarya
Yes,
madam
sir.
is the next speaker ready, ma'am?
Yes, I am.
Yes, ma'am. Then you can start your ma'am.
Okay, sir.
Aishwarya madam can introduce the next speaker, and so that we can proceed. So that we don't lose time, ma'am.
Yes, sir. The next speaker is another stalwart in the field of fetal medicine, Dr. Lakshmi Ravi Selvaraj. She's a consultant and director of Sri Lakshmi Clinic and Scan Center, Krishnagiri, Tamil Nadu. She's been practicing ultrasound over the last 20 years at Kavaripatnam and is one of the leading pioneers with the implementation of prenatal screening in a rural setup. She has set up practice in and around the Krishnagiri district and caters to the needs of antenatal women in low resource settings. In the last few years, Lakshmi Ravi Selvaraj has authored numerous insightful papers in the field of prenatal ultrasound diagnosis and has published over 15 papers on the first trimester evaluation of the fetus. Her specialty lies in the first trimester evaluation of the palate, and she has published over 6 detailed articles on the sonographic evaluation of palatal clefts. Over to you, ma'am.
Thank you, Aishwarya. Just let me know if the screen is visible and if I'm audible.
Yes.
Yeah. So good evening to you all, and thank you for this opportunity to speak on ultrasound evaluation of early pregnancy bleeding. It's very nice that IMA has now included ultrasound obstetrics into their major curriculum, and it is very nice that what I have done in this particular presentation is, of course, there are images, but I would try to incorporate the imaging with the clinical evaluation and how we can go by. So whenever we have early pregnancy bleeding, everybody is in a panic because when the woman when she says that she has bleeding in the first trimester, then the immediate thing is there something going to go wrong with the pregnancy? That's what everybody thinks. And it can be something very simple like a normal physiological implantation bleeding. There can be a very subtle subchorionic hematoma. There can be a failed fetal growth. It can be an miscarriage, or there can be life-threatening conditions like an ectopic pregnancy or a cesarean scar pregnancy. So now, how to identify whether it's a very simple issue or whether it is a major life-threatening condition? It is there where ultrasound plays a major key role. And so the objectives of this presentation would be, first of all, to understand what will be the normal features in an early pregnancy. What is the criteria to say a non-viable pregnancy? Is there a pregnancy with a uterine anomaly? That is, suppose that there is a biconjugate uterus and the pregnancy is in one horn, then she'll keep on bleeding from the other horn. So we need to understand, is there a pregnancy with a uterine anomaly? We have to recognize life-threatening conditions like ectopic pregnancy and a cesarean scar pregnancy. And the importance of a low-lying gestation sac is what I have highlighted in this presentation, because nowadays cesarean scar pregnancy are on the rise, and hence we need to identify that condition and ultrasound features of a molar pregnancy. All of these things will present with early pregnancy bleeding. So these are the features of an early pregnancy. 4 weeks plus, you might see a small gestation sac, and this is the earliest sign of intrauterine pregnancy, which is a small fluid-filled sac. By the 5th week, you will see the yolk sac, and you will be able to see the intradecidual sign and the double decidual sac sign. 5.5 weeks, yolk sac is seen, and in the 6th week, embryo is seen. You have the gestation sac is a small, uniformly rounded fluid collection inside the uterine cavity, and the position is normally in the mid to upper uterine cavity, and it will have a hyperechogenic rim, which is called as a double decidual sac sign, and this will be approximately, as I told you, visible by 4 weeks of gestation. This is how the gestation sac measurement is done. And why is this gestation sac measurement important? Later on, I'll explain to you. So we take 3 measurements and then do the mean sac time. If you see a yolk sac inside the gestation sac, then that identifies that this is going to be the intrauterine pregnancy. So that is the importance of the yolk sac. So for dating, as simple as it is, if you see the 5 weeks, then it is for gestation sac, then it is 5 weeks. If you see gestation sac plus yolk sac, 5.5 weeks. Gestation sac, yolk sac, embryo 6 weeks. A CRL of less than 5 millimeters, you have to look for fetal cardiac activity, whether it is present or not. But generally, you will measure the crown rump length when embryo is more than 7 millimeters. Once the gestation age is assigned by CRL, then we do not change the dates in subsequent scans. That means we cannot have reports throughout the pregnancy with different gestation age. EDD will not be different. If the EDD is assigned in the first trimester, then we generally don't change dates. Now we know how the early pregnancy is, and if you can see the ultrasound features, then you can assure the pregnant lady that there's nothing going wrong. This is just a simple bleeding which will get okay by itself. But there are certain conditions where we can really tell them, no, this is a non-viable pregnancy. That's a failed intrauterine pregnancy. That's the reason for bleeding. So what are the terminologies used and how do we go and how do we say that? Whenever we see an embryo with the visible cardiac activity, then we will say that the pregnancy is viable. When you want to say that you are not very sure whether the pregnancy is viable or not, then the criteria will be if a mean diameter is less than 25 millimeters or you have a CRL of less than 7 millimeters and you cannot see cardiac activity and the patient has bleeding, we have to wait and confirm whether it is a viable pregnancy or not. So at the initial scan, if the mean gestational sac diameter is greater than 25 millimeters with an empty sac, then understood that you can say that this is going to be an indication of a miscarriage. If there is an embryo with a crown rump length of greater than 7 millimeters, but no cardiac activity, then again you can be very sure that this is going to be a miscarriage. When you repeat a scan at an interval, then if you generally if it is in vice versa, okay, then you have to repeat the scan. If the CRL is lesser than 7 mm, then you repeat the scan and then check whether the fetus is growing or not. That is very, very important when we have bleeding, because we should not earlier itself say that this is going to be a spontaneous miscarriage. So we have to wait and check if do a repeat scan and confirm whether the embryo is growing or not. Now, the fundamental principle of diagnosing miscarriages, we must be clear that you have to follow the guidelines and be sure that the fetus, you can see a cardiac activity of 7 millimeters with no cardiac activity, then that is fine. Okay, this is about diagnosing early pregnancy failure. So what I have right now told you is, I have shown you early pregnancy failure, and I have shown you the reasons for the most commonest reasons for implantation bleeding. Now, is my slide visible?
No, ma'am. Now it is not.
Just give me a second. Okay, I'm just once again sharing my screen. Just let me know. Are you now able to see the slides?
Yes.
Yeah. So now this was the last slide I was speaking. And now once we know the basic thing, we know what is early pregnancy ultrasound findings, then we know what is early pregnancy failure, how to diagnose early pregnancy failure. Now we'll have this condition. She might have some bleeding, there will be a positive beta HCG value, but you can't see the sac in the uterus. Then immediately we have to go and check for the adnexa and see whether you are dealing with an ectopic gestation or not. If there is a positive adnexal finding, then it will be an ectopic gestation. If there is, you do not have a positive adnexal finding and there is a normal adnexa, then we have to wait, check beta HCG titers, and then see whether there is sac in the uterus or it's an ectopic gestation. If it is a declining beta HCG titer, then it's going to be a miscarriage. So here comes the importance of ultrasound, clinical evaluation, and also including beta HCG in our armamentarium. So what is the discriminatory zone? It is 1,500 to 2,000 units when you do a transvaginal scan. So only when the beta HCG is greater than that, you will be able to visualize a sac. The average doubling time of beta HCG in a normal viable intrauterine pregnancy is about 48 hours. In ectopic, serum HCG levels rise at a much slower rate, that's less than 60% increase over 48 hours and not steadily declining. The serum beta HCG test yields positive results at approximately 23 days before a normal intrauterine gestational sac may be imaged. So this is what is important. It might, the serum beta HCG might become positive first, but the sac may be visualized 4 or 5 days later. So that we have to remember. In 15 to 20% of ectopic pregnancies and in 8% of miscarriages, beta HCG profile mimics that of a viable intrauterine pregnancy. That's why all three goes hand in hand, your clinical examination, beta HCG assay and ultrasound. Now coming to ectopic pregnancy. So if you have an adnexal mass that contains a yolk sac or a viable embryo, then that is a sure sign of an ectopic pregnancy. So look at this. This is the definitive criteria in the adnexa. So you won't have a sac in the uterus. In the adnexa, you will have a gestation sac and you see the yolk sac here. Here you see in the adnexa, you see a viable embryo and this is how it will look like. This is an ectopic gestation. So it is important we recognize this life-threatening condition also. But most commonly, what we will see on routine ultrasound is whenever she comes with a bleeding and a positive beta HCG values with no sac in the uterus, most often you will see some inhomogeneous adnexal mass like this. This is nothing but the hematoma of the ruptured ectopic pregnancy, or you can see something like a small sac-like structure. This is called as a tubal echogenic ring. And you see free fluid with internal echoes. Once you see free fluid with internal echoes, you can alert the physician and tell them, yes, this is going to be an ectopic pregnancy. So now we know how to diagnose an ectopic and how to identify that. Now, when we come to I'm closing out early pregnancy. So whenever I said there are some criteria. So if you see here, she's primary conceived after 6 years of infertility, 8 weeks by last menstrual period. She's presenting with a history of bleeding PV. And the scan done outside is suspicious of early pregnancy failure. So this is what, when we do the scan, what happens? You see some fluid in the endometrial cavity. If you want to measure this, you think a gestation sac and measure it, then it becomes something greater than 3 centimeters. So by criteria, this is a non-viable pregnancy. But you don't have a beta HCG in your hand. So you really do not know whether this is going to be an ongoing pregnancy or not. So when you do a scan after a week, you see a small sac appearing and then you see you can see the embryo developing in this pregnancy. And that is why no single value should be taken as a proof for diagnosing a miscarriage, and it is always you have to join all 3 parameters. So ultrasound is a strong tool in our diagnostic armamentarium. To repeat, no single ultrasound measurement can predict pregnancy 100% of the time, especially when it comes to the GSAC. If you see an embryo greater than 7 millimeters, no cardiac activity, that is fine. It should not be used in isolation, especially if the pregnancy is desired. There is no harm in waiting. We can wait for a week and then recheck. A combination of clinical judgment, HCG, ultrasound findings, and repeat ultrasound and HCG titers should be used in the diagnosis and management of early pregnancy failure. So this is about early pregnancy, ectopic, and the normal early pregnancy features. Now we'll go to some subtle findings. Whenever a lady presents with the bleeding. You can have something like a chorionic bump like this. This is a very benign condition and we really need not worry about it. As long as the fetus is viable and has cardiac activity, we can follow up this pregnancy. A subchorionic hematoma. This is the commonest finding what we see on ultrasound once the patient complains as a bleeding PV. So what happens is it can be either a small one like this or it can be very large. It can be even more greater than the size of the gestation sac. When we have such large hematomas like this, then we have to wait and watch whether the fetus is growing well or not. These smaller ones, okay, they will settle by itself. But large hematomas, we need to do a repeat scan and check if everything is fine with the fetus. Whenever we have a hematoma like this, it is ideal that we evaluate the position of the sac. Why is this important? See, here the gestation sac is in the upper half of the uterus. Here you have a hematoma in the lower half, no problem. But when you have a hematoma in the upper half and the sac is low lying here, if there is a low lying gestation sac like this, we should not simply think it is going to be an inevitable abortion and walk away, because these are the areas where we can miss out on important findings. So what is it? Whenever we have a big hematoma like this, and the complaint of the patient will be bleeding PV, and you have a gestation sac like this, immediately when there is a low-lying gestation sac, we have a protocol to follow. What do we do to identify whether it's a simple inevitable abortion or it is a low implantation of the gestation sac? That is very, very important. So when generally the sac will be in the upper half of the uterus. See, this is where the sac is generally implanted. If you have a low-lying gestation sac like this, again, you have to be very alert. Instead of a low-lying gestation sac, the sac is generally in the middle of the uterine cavity. If it is eccentrically located like this, once again, we have to be alert. So these are the two reasons, times whenever you see the sac either low lying or eccentrically placed, we have to be careful that whether we are dealing with a problem which is life threatening to the woman. So we'll see what is that. So whenever there is a low lying gestation sac, the low implantation of the sac can be a precursor to a morbidly adherent placenta. It can be a simple inevitable abortion. It can be a cervical pregnancy or a cesarean scar pregnancy. So what happens in a cesarean scar pregnancy will be the sac will be implanted at the cesarean scar. What will happen? The gestational trophoblastic tissue will grow anteriorly through the myometrium and it will cause thickening of the anterior myometrium. So the criteria for a scar pregnancy is an empty uterus, empty cervical canal, development of sac in the anterior part of the lower uterine segment, and absence of healthy myometrium between the bladder wall and gestation sac. So just this is a sac, it is lower down. There will be a previous history of LSES. The cervical canal is empty and you see the trophoblastic tissue is growing anteriorly and you see thinning of the anterior myometrium and you see this peritrophoblastic flow. This peritrophoblastic flow is the key sign for
Excuse me, ma'am, your connection. We're not able to hear you. I think there is a network issue. I'll just get back.
Madam, shall we start with the next talk? So meanwhile, Madam will join.
Sir, the talk is not over, sir. It is halfway.
Okay.
Just a few more slides, sir. It will be over.
Okay.
And Dr. Aishwarya, can you able to come?
Sir, ma'am needs to be unmuted. Dr. Lakshmi Ravi, ma'am, she needs to be unmuted. The host is not allowing that, I think.
1 minute, 1 minute. What name, ma'am?
Dr. Lakshmi, Madam. Dr. Lakshmi Ravi.
Ravi Selvaraj.
No. That name is not there. Maybe ma'am should have joined some other.
Hello? Lakshmi Selvaraj, sir.
Okay, fine. I have unmuted. Hello, am I audible?
Yes, madam.
Yes, ma'am.
Yeah. Okay, you also have to allow me to show my screen.
You are a host now, ma'am.
Screen sharing is also disabled. Yeah. So, Aisha, can you just tell me where exactly was the connection cut when I was dealing cesarean scar pregnancy?
Yes.
Okay, fine. So, were the slides on cervical pregnancy seen?
I think slide number till slide number 28.
Oh, great. Okay, fine. I'm showing slide number 29 now. Yeah. So I was speaking on this till here where the connection was the connection intact, Aishwarya? Are you able to see my screen?
Yes.
Okay, great. So this is about the cervical pregnancy, what I was telling. This is once again another life-threatening condition where the sac is implanted in the cervix. Now, whenever we have an inevitable abortion, what happens is the anterior and the posterior lips of the cervix will be splayed and you have gestational trophoblastic material coming out. And the important finding is there will be absence of peritrophoblastic flow surrounding this sac. This is how we identify that this is an inevitable abortion. So this is for the imaging people. We have published a paper called as low-lying gestation sac, where clearly how to identify between an inevitable abortion, cervical pregnancy, and cesarean scar pregnancy is clearly mentioned in the tabular column. Now, coming to the clinical importance of this low-lying gestation sac. By ultrasound, actually, if you see, both these pictures are looking more or less the same. But actually, this is an inevitable abortion because the anterior and posterior lips are separate and the whole thing is coming out. We really need not worry in this condition. But what happens here is actually the cervix is intact. The whole placenta is actually implanted in the lower uterine segment. And if we go for a curettage in this patient, there will be torrential bleeding. So that is how ultrasound really helps us to identify whether you can touch the patient or not. Because here the anterior and posterior lips of the cervix are not open. They are intact. And this is a complete low implantation of the whole placenta. With and the patient will present with a severe bleeding PV. And the identification clue is the presence of trophoblastic flow here, and that clearly tells you that this is not an inevitable abortion but a low implantation of GSAC. That is why a good ultrasound whenever there is a pregnancy, early pregnancy bleeding, it will also be life saving in many times when we encounter such cases like this. So this is once again an algorithm of how to handle a low-lying gestation sac. The Doppler flow is very important. Based on the absence or presence of peritrophoblastic flow, we come to a diagnosis, whether it is an inevitable abortion or a cervical pregnancy or a cesarean scar pregnancy or a low implantation of GSAC. Okay. Now, we have finished completely low-lying gestation sac. Now, if the sac was not in the midline, but somewhere it is to the lateral end of the uterine cavity, once again, it becomes important to identify what the problem is. You see, in the transvaginal scan, the sac is not inside the endometrial cavity. It is separate from the endometrial cavity, and you have peripheral vascularity surrounding the sac, and this is actually an interstitial pregnancy. This is again what happens. You see the sac growing like this. The myometrium thins out and it will go for a rupture. So it's very important that we identify this condition. But not always eccentrically located gestation sacs are interstitial pregnancies. So you don't see the sac in the midline, but you see a sac here. And this is nothing but there is viable pregnancy here. But we need to identify what that here in this case, the endometrium is in continuity with the GSAC. Once you know the endometrium is in continuity with the GSAC, then you can use the advantage of 3D ultrasound and understand that the sac is actually inside the endometrial cavity. This is only an angular pregnancy. We need not worry. So to differentiate between an interstitial and angular pregnancy, once again, ultrasound helps. What's a true cornual pregnancy? A true cornual pregnancy is a pregnancy in the rudimentary heart. So this again is a condition what we all have to really identify. See, this is the uterus. She is pregnant, but you see the sac separately from the uterus, and you see that there is a thick myometrium surrounding the sac, and there is a vascular pedicle joining the G-sac to the uniconnovate uterus. So this is actually a uniconnovate uterus and a pregnancy in a non-communicable. Can you hear me?
Yes, madam. Now we are able to
You're
connect
able
you.
to, right.
Yes.
So I was just discussing about what can be the types in an eccentric gestation.
Madam, again, it's not audible.
Stuck, ma'am. I think there is a problem in the internet connection.
Yeah, network issues that I think.
No, I am unmuted. Can you hear me?
Yes, ma'am.
Yes,
Now we
madam.
can
Now
hear
we
you.
are able to hear you,
Okay,
madam.
fine. You're able to hear me. Okay, once again, I'll share the screen.
It was getting stuck.
It was, yeah, there is some. Okay.
Yes.
Am I audible now?
Yes.
Yes, ma'am.
Can you see
Yes.
the screen? Great. So now,
Yes.
just now I finished about the eccentrically located gestation sac and what is the importance of whether we are going to identify the sac location, whether it is going to be a rudimentary horn or a uniconuvate or a biconuvate uterus, all these things we can identify. Now, the next thing what I was trying to tell you is molar pregnancy. In a complete mole also, you will have bleeding like, am I audible now?
Yes, yes.
Okay.
Yes, madam.
Okay, fine, great.
Green one.
Is the slide visible, ma?
Yes. The last.
Is a complete molar pregnancy slide thing?
Yes.
Okay, fine. So this is how it would present in an early pregnancy bleeding with the complete mole. This is a partial mole where you can have a fetus and you can have the placental vesicular appearance of the placenta. So to summarize, exercise extreme caution with regard to last menstrual period on history taking. Women tend to forget their menstrual age. So generally, we always have to correlate with ultrasound and beta HCG values. Visualize all of the uterus and don't neglect to scan the adnexa because you can have a heterotopic pregnancy. Avoid labeling subchorionic bleeds as additional gestation sacs. That's very common. Recognize molar pregnancy, pseudosacs, and chorionic bumps. All these are common things which we have to identify in ultrasound. Missing an ectopic and misinterpreting a normal intrauterine pregnancy as an ectopic. Both can be avoided by meticulous scanning. Women presenting with bleeding PV and low-lying gestation sac in early pregnancy needs a thorough ultrasound evaluation to arrive at a correct diagnosis. It is essential for every clinician to watch out for cesarean scar pregnancy in women who conceive after cesarean and actively involve the patient in decision making after discussing the available treatment modalities. Ultrasound has an important role and meticulous attention to the subtle markers helps to differentiate the benign conditions from life-threatening ones. Thank you so much for your patient listening.
Thank you. Thank you so much, ma'am, for the elaborate presentation on early pregnancy bleeding. There's only one question. Because of the rising rates of cesarean sections in the last decade. So once a patient has a cesarean section, when she's planning to conceive a next pregnancy or as soon as she conceives, when should she come for her first scan?
Great. It's a very nice question. And generally what I would advise is whenever you send back a patient with a cesarean scar after the cesarean, you can just say report to us at 6 to 8 weeks in the next pregnancy. Okay. Because generally, even if you see a patient, okay, at the 11 to 14 weeks scan for the first time, there's no harm at all. Doesn't matter. But in a cesarean scar pregnancy, we must see her between 6 to 8 weeks. Only then we can be able to identify. No, we can identify at any point of time. But before complications, if you want to identify, it should be at between 6 to 8 weeks. That is the time period where the cesarean scar pregnancy, the cesarean, after a cesarean section for the next subsequent pregnancy, she has to report to you between 6 to 8 weeks. That's the right time.
So if there is a patient who has a beta HCG of 1050 and we are not able to see an intrauterine or an extrauterine sac and there is no free fluid, we are not able to, it's a pregnancy of unknown or location. We don't know where it is. When do we call her next for the next scan?
You can, yes, you first need to do a repeat beta HCG titer.
Okay, after
to see what is happening to the beta HCG levels. Then after you have a beta HCG titer, then you can call the patient back. If you have a rising beta HCG titers, well, you can call her back after 4 days and recheck.
That's all. That's all the questions are. There is a question. Is the sterilization always mandatory while doing laparotomy for evacuation of an impending rupture of cesarean scar pregnancy?
Okay, well, that is again you and The patient has to decide and then
Depends
take
on
the call.
her history, yes. On
Correct.
her
It should be an informed choice taken by the patient and you, is it not? Because before you are going to do that, you obviously would know that it's a cesarean scar pregnancy. So before, or I think you should discuss that with the patient and then take a choice. What do you feel, Aishwarya? I think you will be a better person to answer this question.
Yes, ma'am, that is a informed consent that has to be given by the
Yes, by the
It's
patient.
not that we cannot, at any point, for any case, we cannot do a sterilization on a forceful, consent. That's all, I think.
Thank you so much. Thank you. Thank you, everybody.
Next, can we go on to Sir Dr. P. Devarajan, sir? I have just introduced him previously. There was a network issue. Sir, are you ready, sir, now?
Yes, ma'am. Yeah. Let me go ahead.
Yes, sir.
Yes. Yeah. Are you able to see my screen?
Yes, sir, we are able to
see. Okay. So, yeah. So before going into the Doppler, obstetric Doppler, we just see the Indian scenario of pregnancy. So we have large number of pregnancies, like about 28 million pregnancies annually with 26 million live births and 67,000 maternal deaths. There's a huge maternal deaths in our country. So 1 million neonatal deaths annually and 7.5 lakhs of perinatal deaths. So that too, India has highest number of stillbirths in the world. Stillbirths refers to the death of fetus after 28 weeks of pregnancy, but before birth, in utero. So the stillbirth rate is about 22 to 66 per thousand live births. So if you look at the scenario, it's even India has more number than the Nigeria. That could be due to high population, but however, as per the scale is concerned, we are in the topest in the stillbirth. So that's not good. When there's something in the negative, we are in the top. So there is very high instance of low birth weight in India. So more than 20 million low birth weight infants are born each year in developing world, particularly in Southeast Asian countries. So in this perspective, what is the relative prevalence of adverse pregnancy outcomes in India? So prevalence of low birth weight as per WHO and UNICEF is around 30%. May not be exact, but around 30%. And incidence of hypertensive disorders in pregnancy is about 10 to 20%, 10 to 12%. And incidence of preeclampsia is about 8 to 10%. Among these 8 to 10%, about 1 to 5% is going for eclampsia. And the maternal mortality rate is 13 per 10,000 live births. That means we are losing one mother for more than one mother for every 1,000 pregnancies. You think, so we are, there is risk for aneuploidy. 1 in 1,000 pregnancies, there is a risk for aneuploidy. But we are losing more than one woman for 1,000 pregnancies. So we are doing so much of talks and so much meticulous attention to detect one Down syndrome, but are we doing enough to prevent the maternal deaths? The prevalence of congenital malformations, when we compare to all these things, it's very low, about 1.9 to 2.7%. And the congenital heart defects, that too, it's 0.6, and neural tube defects 0.2, and Downs it's 0.1%. But we are doing enough job, reasonably enough job all over the country, even in the peripheral setups. Now the aneuploidy screening NT is coming up, and we are doing fetal echo reasonably, and the anomaly scan, we have good advanced machines. But are we doing enough to do the things which is in the top, that is preeclampsia, hypertensive disorders, and the low birth weights? So that's where our obstetric Doppler comes. So it is the Samrakshan is a program by Indian Radiologists Association. It's a national mission targeting perinatal mortality in India. I was I am one of the course director of this course, and we have published the rationale for universal first trimester screening to identify pregnant women at risk of preterm preeclampsia in India. So this was the paper we published, and we will go ahead with the few clinical aspects of preeclampsia that we all might be knowing. The all obstetricians would be, it's not the new for them. So it's a multi-system syndrome developing during second half of pregnancy, characterized by hypertension, proteinuria, and maternal organ dysfunction. And its incidence is about 8 to 10% of pregnancies. What happens in preeclampsia is, because of some unknown reasons, the uterine blood flow is reduced and the placenta become ischemic. So this ischemic placenta releases some factors like endothelin, thromboxane, etc. All these things will cause vasoconstriction, so that the total peripheral resistance increases. The women will have hypertension. So the renal pressure, natriuresis will go down. So all this is the basis for complications coming out of the preeclampsia and eclampsia. So the maternal complications because of that may have cerebral signs, pulmonary edema, liver dysfunction, hepatic failure, oliguria, all these things. And fetal complications, we all know that IUGR is it's a complication of preeclampsia and premature delivery, abruptio, fetal distress, fetal demise, everything can happen. So what are the factors associated with preeclampsia? So one is age, every 5 years above 35 has high risk, and height, that's the lower the height, that's higher the risk. And the weight, it's higher the weight, it's higher the weight, higher the risk. And Afro-Caribbean and Southeast Asian population has inherent high risk for preeclampsia. We are coming Southeast Asian, so South Asian. So we are also, the Indian population is inherently high risk for developing preeclampsia. And in IVF pregnancies, chronic hypertension, diabetes, SLE, antiphospholipid syndrome. So all these things have the tendency to have high risk to become preeclampsia. And the family history of preeclampsia, then we have this also a risk factor. And parents without preeclampsia is low risk, but parents with preeclampsia, it's high risk. And of course, the mean arterial pressure. So increased mean arterial pressure is one of the risk factor for developing preeclampsia. FGR, it's a failure to achieve endorsed growth potential. It's defined with either estimated fetal weight or abdominal circumference below 10%. Not only that, with associated Doppler changes, like we will discuss it later. And the IUGR will have increased perinatal morbidity and mortality into tenfold. So you see the all sort of perinatal and neonatal complications like both asphyxia, hypothermia. So everything will be into tenfold when we deal with fetus with IUGR. We have to ready for that. So if you look at the causes of IUGR, there are long list of causes: any maternal disease, chronic disease, and placental and fetal causes like any aneuploidies or any the single gene disorder, whatever it is. But if you look at the relative frequency, 80% is due to placental insufficiency, and the rest are very small percentages. So when in this, so we will go to the overview of Doppler in obstetrics. What we are going to apply the Doppler in obstetrics in general. So in first trimester, we are doing uterine aortic Doppler as a part of combined preeclampsia and FGR screening. So from the result of that Doppler and screening, the screen positive woman was started with prophylactic treatment with low dose aspirin. In second trimester, we are doing uterine aortic Doppler for deciding monitoring. And in third trimester, we are doing it the umbilical artery, middle cerebral artery Doppler for early diagnosis of IUGR and staging, follow-up, and timely delivery. In particular, and needed, we need to do ductus venosus at all. And also, we have to do uterine aortic Doppler also in third trimester. So Doppler in first trimester. So this man, we all know, it's Kypros Nicolaides. They inverted the pyramid of care, antenatal care. So it's traditionally that our attention is it's large in third trimester and after second trimester particularly. That's because most of the time the antenatal, most of the time the complication, obstetric complications start manifesting in the third trimester. So our attention is towards third trimester that increased visit, antenatal visits, more monitoring. So that's what the traditional antenatal care. But initially, in the only pregnancy confirmation will be done in the first 3 months, that is first trimester, and the anomaly scan in second, and that's what it was there, but it has failed. So because by this care, we have not attained any the long-term outcomes in preeclampsia and IUGR, or the morbidity, mortality, the perinatal mortality, that's not changed for many decades. That's what we need to relook our service and relook our care. So that's all the pregnancy care is inverted. That is 12 weeks of gestation. So we need to evaluate the pregnancy completely. We need to divide into high risk and low risk in that particular point. So after that, then the low risk women can be just monitored, but high risk has to be put in special care. That's what the inverted pyramid of care. That is the rule now. So as like the preeclampsia, so in 11 to 13 weeks, it's time we have to apply all these things. That's complete the combined aneuploidy screening, as like Dr. Manigan was talking previously, and detailed anatomical survey, early cardiac evaluation, and the its important part is combined preeclampsia screening. That is uterine artery, mean arterial pressure, history, PLGF, and screening for SGR and FGR. That's a part of the preeclampsia screening itself, and screening for preterm delivery, the cervical length, screening for GDM. So all the screenings has to be applied at 11 to 13 weeks, and we have to decide whether this pregnancy is fine or we have high risk. So so as this part we are going to discuss in detail, the combined preeclampsia screening. So screening for preeclampsia at 11 to 13 weeks by FMF algorithm. The objective of our screening is to identify the cases that do benefit from prophylactic use of aspirin. So traditionally, the obstetrician used to decide it with the risk factors, that is history alone. That is whether the mother is obese or is having any previous hypertension, diabetes, whatever it is. Based on that, we can detect up to 50 to 50% of cases. But if we add with the history, if we add doing mean arterial pressure assessment, the detection rate going to, that is early preeclampsia up to 65, and late that is the 37 weeks, that preeclampsia at 60%, and the late preterm preeclampsia that is manifesting up to 37 up to 40%. So if we add with the mean arterial pressure, if we add measuring uterine artery PA, uterine artery Doppler, then detection rate again increases. And if we add PLGF, the biochemical markers, then we are getting almost 90% detection rate. That is early preeclampsia. And the late preeclampsia, the detection rate will be very low, even with application of screening. This is because of the most of the cases is associated with chronic hypertension, that is pre-existing hypertension. So many things are there, so that cannot be detected with the screening. But that early preeclampsia, it's a huge number of cases we can detect by applying the meticulous application of combined preeclampsia screening. So so what is the evidence to say that combined preeclampsia works and it benefits our women? And so for that, the FMF itself done a large, very large multicentric international trial that's called ASPRI trial. It's for its expansion is aspirin for evidence-based preeclampsia prevention. It's done with 27,000 singleton pregnancies conducted by FMF. So this is how what is done in this study is at 11 to 13 weeks. So the meticulous FMF algorithm is applied. That is maternal history, measurement of uterine artery PA, and mean arterial pressure, and biomarkers. So all screen positive women were allocated to low dose aspirin from 12 to 36 weeks, and results were analyzed. So what they concluded, it's published recently, it's in 2018, it's published in. So proper application of screening and administration of aspirin at 11 to 13 weeks was associated with 8 to 2% reduction in the incidence of preeclampsia, that is before 34 weeks. Look at the number, the percentage. So can you imagine like a country like India and the huge load of preeclampsia and hypertensive disorders and eclampsia maternal deaths. So if a method that is prevents 80% of the preeclampsia, so how good it is for a country like India, and how it's an opportunity for all the healthcare provider to apply this. So this is what the crucial thing. Every obstetrician, radiologist, and fetal medicine specialist who is doing fetal maternal care, first thing we have to do the preeclampsia and IUGR screening at 11 to 13 weeks, applying all these algorithms. So that is the key point in reducing perinatal mortality in India. So that's what we are propagating through IRIA in the program called Samrakshan. That's what we are going to deal with. So the combined preeclampsia screening for preeclampsia and early onset FGR. So in this algorithm, the first three steps, that is recording maternal history, height, weight, and measurement of mean arterial pressure and measurement of uterine arterial pH, it does not need any additional resource than existing one. That is no financial cost involved in this. So already patient is coming for anti-scan. We are anyhow asking history, and only thing is BP apparatus. So the automated BP apparatus that's cost around 1,200. Only that is the financial need. All other things are already existing. Already we are doing the ultrasound and Doppler that we can utilize. By applying these three alone, we can detect up to 70 to 80% of the detection rate is up to 70 to 80% for early preeclampsia. That is the target of Samrakshan, that is Indian IRA program to detect preeclampsia and early onset IUGR. So this we can do in every setup. No need, even in GH we can apply this. That's what I have given this talk in so many government hospitals, including the National Hospital of Sri Lanka. That was only the big government hospital in the Sri Lanka. I have just give a demonstration and asked them obstetrician there to do throughout the country. So there is a huge thing that we can do without additional financial cost. So for the patient's affordable, we can measure PLGF or PAPA, or the patients who doing that double markers already, and the PAPA is already done doing. There we can do the additional these three algorithms and put the complete algorithm. So if not, the patient cannot afford for any additional markers, biomarkers. This is enough for our setup. This is more than enough to detect up to 70 to 80% of preeclampsia. So step one. So we will go into the algorithm. The step one is the taking maternal history. That's what we are always doing. But for the radiologist, it's they have to get this habit of taking maternal history when the patient comes for anti-scan. Particularly when we do we have to implement the preeclampsia screening as a part of anti-scan. So the racial, so everything there will be column. If you do a preeclampsia, this format will have all this column. You have to just tick it. The preeclampsia, then chronic hypertension, diabetes, and all these things we have to do. And the second is measurement of mean arterial pressure. It is nothing but taking a BP in some particular way. That's BP should be taken by automated device, taken simultaneously in both arms. The woman should be in sitting position and their legs should not be crossed. The arm should be supported at the level of heart, and the normal adult cuff should be used. After this for 5 minutes, 2 measurements taken at 1 minute interval. Readings are applied in software for the risk assessment. So it's nothing but, so you should not do it as like we do routinely. You have to do it with 2 automated devices on both sides simultaneously. And all these measurements, just you take 2 readings and I will show how it has to be filled in the form. So next is, third step is uterine artery Doppler at 11 to 40 minutes. So uterine artery Doppler, the anatomy at this stage, that is 11 to 13 weeks, is it will be the uterine artery. If you look at the anatomy, it's at the level of cervicoisthmic junction. It's come adjacent to the cervix and divide into multiple branches, myometrial branches. So you have to see you have to focus the cervix first. You get the cervix and put the color box, and you just tilt the transducer. You will see here. So if you tilt the transducer towards the side of the cervix, you will see the uterine artery. So the pulsating one, that is the uterine artery. You put the pulse rate Doppler there. The gate should be 2 mm. Angle of inclination should be kept less than 30 degrees. The technical points, it's very easy. Just the pulse rate Doppler gates should be 2 mm. And there will be an off that angle because we need to correct it. I say why it needs to be corrected because so PSV of sampled uterine artery should be more than 60 centimeter. So why this? Because if it is less than 60 means we may inadvertently sampling the any branch of uterine arteries like orbit or radial artery. So it's always mandatory that the PSV should be seen and it should be more than 60. Since we are looking at PSV, we are angle correction also we are doing. So it should be kept less than 30 degree and the PSV should be more than 60 to make sure it is we are taking proper uterine artery Doppler. We have to do it on either side, make it an average of it. So sometimes it will be difficult to get the cervix. That's why to get the uterine artery. So ask the patient to wait and fill the bladder partially. So then in that case, you will see the cervix as well as uterine arteries easily. And if it is doubt or it's difficult to do it transabdominally, always do a transvaginal scan. So because don't hesitate to do transvaginal scan for the purpose of taking uterine artery sample because it's very crucial. We need to do a perfect uterine artery Doppler PI value on either side to get a perfect screening. That is perfect screening results. That is either screen positive or not. And based on that, we are starting aspirin, low dose aspirin, that we are going to detect that reduce the incidence 80%. For that, we cannot do that transvaginal. So we can do. So transvaginal is easy and it's very perfect uterine artery we can get. See, look at the transvaginal scan. See, just the cervix. I'm seeing the cervix. Just put the color box and tilt the transducer towards the side of the cervix. That's it. See how easily you could get the perfect uterine artery sampling. So that's what we have to achieve. So at any cost, you must get perfect uterine artery Doppler. So in 11 to 13 weeks, that is mandatory. You all who are listening, you listen carefully and do it from tomorrow itself. So this is the nomogram for uterine artery PA from 11 to 41 weeks itself. So there is a nomogram available. So average PI of both uterine arteries has to be taken. So you should not take either one side. We have to do it both sides and make it an average. And that average, you have to put it in this nomogram. So if the average PI of both uterine arteries more than 95%, then we are calling it as high resistant. Presence of early diastolic notch, we are no more using because the PI is more specific than early diastolic notch. So it's always better to use PA only, not early diastolic notch. So what happens in uterine artery Doppler preeclampsia? So abnormal placentation leading to uteroplasmal insufficiency and end up in preeclampsia or early onset FGR. So that the mechanism is when once the pregnancy happens normally. So the terminal arteries of uterine circulation is called spiral arteries that will be there at endomyometrial junction. So once the pregnancy starts, that we call it as decidua. We don't call it as endometrium. So these decidual cells, what happens is this, it engulfs the wall of these spiral arteries, terminal spiral arteries, and it destroys the smooth muscle layer in the spiral arteries. So without smooth muscle to contract, this end of the spiral arteries hugely dilates during pregnancy. That's why it allows large blood pool into the placenta, so to the fetus, and it's the normal pregnancy continues. But in abnormal placentation, because of some unknown reasons, this trophoplastic invasion of the spiral arteries does not happen. So with the presence of smooth muscle, it keep contracting as like pre-pregnancy state. That's why it won't allow blood to the placenta. So that leads to placental ischemia. And as I said, placental ischemia gives all sort of complications. So because of this, what Doppler can detect? because in the normal, the spiral artery remodeling, that is the dilatation of spiral artery. So this is the how look at the Doppler waves. The uterine artery Doppler in pre-pregnant stage becomes like this when the spiral artery dilates normally. So the diastolic flow will hugely enlarge, increases, and resistance becomes drops. So that it is called low resistance flow. That a good flow for uterus and pregnancy. And what happens in abnormal placentation, that is early preeclampsia and IUGR, is its pre-pregnancy pattern of waveform, that is high resistant waveform, continue to be there even in the second trimester also. It starts with the remodeling starts in the first that is in the first trimester itself, and it peaks in the second trimester, that's early second trimester. But in the abnormal placentation and preeclampsia cases, it will be persistently high resistant starting from 11 weeks, even at 16 weeks also. So that's what we are going to detect during uterine artery Doppler. So how once we do all these three steps, how we calculate the risks, that we have the FMF website calculator. So you can easily learn it and train your staffs to do that. So there is a page, and in the FMF Fetal Medicine Foundation website, the 11 to 14 weeks, there is calculation software will appear in the corner. You have to just click it, and all these three steps will be there in the columns will be there. You just fill it up, and finally you will get the calculate risk. Your software will give the risk. That's 1 in 81, 1 in 106, like that. How will you interpret the risk? So high risk group is risk of preeclampsia more than 1 in 150. So in these cases, if the final result comes 1 in 150, you have to start with low dose aspirin of 150 milligram taken at bedtime from 12 to 36 weeks, and it will reduce the magic number of 80% of. But that will happen only if the compliance is more than 90%, and make sure that it is 150 milligram, not 75 milligram. Okay, because the in the aspirin trial itself, they have checked whether the 150 or 75 which is using the most, but they come to conclusion that only 150 milligram is adequate dose to reduce preeclampsia. So it is not, it's 150 is not high dose. There are so many obstetricians fearing that it will cause some other the GI symptoms, whatever it is, or complication. Nothing will happen. So it's 75 milligram is no more used as per standard. It is 150 milligram always. You don't use 75 milligram anymore. I have checked. I have get feedback from a lot of obstetricians that after we have insisting this to the 150 milligram, even after 150 milligram, there's no side effects. Okay, and low risk group, that's if it is less than 1 in 150, it can be reassured, and reassessment should be done at 2 weeks. So it's the chart showing the high risk mother has to be started on aspirin and assessment at 22 weeks, and low risk mother just reassessment at 22 weeks. No need to do anything. Doppler in second trimester, again we have to do second trimester uterine artery Doppler. So that's easily done during anomaly scan. Just you have to take your probe to the side from the midline. Just go to the side and put the color box. You will see the iliac vessels. You will see a vessel crossing the iliac vessels, that is uterine artery. So you just take the sample. So in the same way, we can detect a risk also in the second time, applying uterine artery parameters in second trimester. So the high risk group is again 1 in 150. So, but when as reassessing the mother at second trimester, make sure the high risk group is already started on aspirin and taking it regularly. Then do reassessment, because so many times we have done the meticulous uterine artery first trimester thing for preeclampsia, and we have suggested, but may not, whether women may not take it regularly, or it's not at all started. So always make sure that, and cross confirm with your referring obstetrician, whoever it is, and it has to be followed. Complaints of 90% should be there to reduce, to see some result. So high risk group again. So already in persons of aspirin, if till it is in high risk, means these are the cases. It will manifest preeclampsia in second or third trimester, towards third trimester. So in that cases, we need to monitor closely, and that is once in 2 weeks or 3 weeks, the growth monitoring, Doppler, everything has to be done. And low risk group, that's more than less than 1 in 300, can be reassured, and reassessment can be done at 36 weeks. And intermediate risk group, reassessment at 32 weeks. That means the 150 to 300. So protocol for third trimester scan. So once the second trimester, what we do is just doing uterinotomy Doppler, and if it is still high resistant, then we whether the patient is in aspirin or not, then these are the cases more likely to have either preeclampsia or early onset IUGR. So in that cases, we need to do frequent monitoring, like 4 weeks, 3 weeks, like that, and or if it is low risk, we can rescan at 32 weeks. The growth scan can be done at 32 weeks, but if there is high resistant flow in uterine arteries in anomaly scan, then always to start at 26 weeks itself. At least one scan 26 to 28 weeks. Then if it is normal, then we can do 32 weeks routine growth scan. So during the growth scan, what you are going to assess first is starting point. You have to decide gestation age based on dating scan, not the biometry you are doing at 32 weeks. That is there are few doing like that. So just putting the biometry, taking the biometry and average biometry gestation age, they putting even in the 32 weeks. That's very wrong. So you have to look at the starting point. That is, you have to ask the patient to when the dating scan, look at the NT scan. So before putting your probe, you must decide what is gestation age for that pregnancy. You don't go with the biometry, but then you do biometry. That is, then put it in the plot chart. That you will give, it will give assessment of growth, whether it is up to the gestation age or not. Okay, we are not going to, we should not decide gestation age based on the biometry. That's very wrong way. And assessment of amniotic fluid volume, AFI, SDB, look for the signs of oligohydramnias, and anatomical survey, look for anomalies. That is, sometimes there may be anomalies missed in the second trimester, or there may be evolving anomalies. So always have a gross anomalies screening. And Doppler, uterinotomy, umbilical artery, MCA has to be done routinely. There are benefits for that. We have done a study. So routine uterinotomy, umbilical artery, MCA Dopplers having some thing, that is, there are some cases like the directly umbilical artery may show high resistant flow. Then that cases, if you follow, even though growth is adequate, but end up in a UGR later on stage. So always do a Doppler at third trimester scans and serial scans for growth, not less than 2 weeks interval. And ductus venosus and itismus only in cases of established IUGR already. So they do a perfect biometry, mention the growth in percentiles, not in weeks. So put it in the plot, that is growth chart, and it gives a visual assessment of whether growth is going into the line of 5th to 95th, or it is crossing the 5th line. It's easily identify that. So based on this, we will come to the pattern of fetal growth, whether it is normal. The normal means 10 to 95th percentile, that is approximately gestation age. Decrease, less than 10% means it could be small for gestation age, physiological, when every other things are normal, but it could be pathological. It's fetal growth restriction. We have to differentiate when the less than 10% growth. So that we will see in the next slide. So increase more than 95th percentile, large for gestation age, that could be GDM, complicated pregnancy. We have to relook into the diabetic status in the cases. And so the Doppler diagnostic marker. What are the diagnostic marker? Uterine artery, umbilical artery, and middle cerebral artery used to diagnose IUGR. And prognostic marker, umbilical artery is both prognostic and diagnostic marker. And the purely prognostic markers are ductus and aortic isthmus. So aortic isthmus we can leave, but rectus we must. When cases of IUGR, so we have to prognosticate the severity of IUGR. We have to do the ductus also. So as I said in the previous slide, growth less than 10% means how will you differentiate between FGR and SGA? So FGR is equal to if estimated fetal weight of less than 10% plus any of these three. That is either uterine GPA more than 90% or CPR is less than 50% or EFW is less than 3rd percentile itself. So any of these three is met, it is has to be called as FGR. No more it is SGA. So previously there was dictum that FGR is abnormal umbilical artery. No more it's not. No more it is useful because there are the cases umbilical artery is normal but CPR is low, but it's end up in an FGR. So huge number of cases are missed when you look at only umbilical artery abnormality. So it is no more use. You have to. That's the reason criteria is you have to look at uterine artery PA, CPR, and EFW. EFW is less than 3rd. It's directly even without Doppler change. You have to put it as FGR or CPR, and uterine artery is abnormal. In that case, it's less than 10% is FGR. So we have to divide this early onset FGR means that 32 weeks, less than 32 weeks at diagnosis, or 37 weeks at delivery, before 37 weeks at delivery, or late onset FGR more than 32 weeks. So remember, 32 weeks is the point. Before that, it is early onset. After that, it is late onset. So there are key difference between both early and late onset IUGRs. So early onset IUGR, it's 1%, but we can diagnose easily because its growth will lag starting from the mid trimesters itself. And the placental disease is high, and preeclampsia incidence is high, and the association is high. And tolerance to, because it is early onset, the fetus will habitually tolerate to the hypoxia. The fetus adopts itself for hypoxia. But the management is difficult. We have to push it up to 36 to maturity. That is very difficult. So the high mortality and morbidity there. When come to late onset IUGR, so up to 32 weeks, there is borderline insufficiency, but up to 32 weeks, it won't cause any problem. That means the 32 weeks, everything will be fine. The even fetal growth, weight, everything is fine. But once the fetus grown up to certain weights, in that particular weight, in large weight, that available placental reserve is not enough. That means, so the fetus is at 600 grams, 700 grams, the placental perfusion is enough to maintain that. But once crosses 1.2 kg, that the available placenta reserve may not be enough. That is borderline placental insufficiency there already. So that will manifest after 32 weeks. But here the problem is, up to 32 weeks, the fetus is well maintained with oxygenation. But after that, it starts the insufficiency. Then uteroplacental insufficiency happens. This hypoxia, first time it's exposed after well-nourished fetus that won't tolerate the hypoxia. That is the reason late onset IUGR it's very difficult to diagnose and risky, very risky to manage, because once the growth is adequate, we don't bother about Dopplers, because many are not doing Dopplers. Once in 34, 35 weeks, the growth is okay. And why do you doing Doppler? So that's what the dictum so far, but it's not like that. Late onset IUGR can be, the growth may be adequate, that up to that point. Then after that, growth lag starts. Sometimes even before growth lag starts, fetus may show the hypoxic things like MC abnormality, CPR low, everything can happen. So in that case, we have to be careful when we doing the 3rd trimester assessment after 32 weeks. Always include a Doppler as the criteria. And in the late onset IUGR, look at the incidence is 5 to 7% of pregnancies. But we are not diagnosing it, because we are diagnosing more of early onset IUGR, not late onset, because its problem itself, its diagnosis is a problem. We don't have any clue for late onset IUGR routinely. That's why it's missed. Most of the time, end up as the adverse perinatal outcomes like stillbirths. Most common cause of stillbirth is undiagnosed late onset IUGR. So that's why we have to crucial in dealing with late onset IUGR diagnosis as well as management. So low mortality but poor long-term outcome can happen in late onset IUGR. Sometimes the neurological outcome can be poor because of cerebral hypoxia. So all these things can happen. So early onset court restriction, cascade of events is very well known. We all know that it starts from uterine TPA at first trimester itself. From that only we are diagnosing it. So in duets, if you duets second and third trimester, there will be gradual progression from reduction in CPR to umbilical artery abnormality, then midcillar artery abnormality, then umbilical artery end diastolic flow, absent end diastolic flow, then reverse end diastolic flow. It's a clear-cut cascade of events will happen. This time-bound cascade. So once the absent happens, the reverse will happen within a week. So once an umbilical artery high resistance happens, absent may happen within within a week. So there is a time-bound progression to the worsening. So that is the history in early onset IUGR. So in this case, we have to be very sure that when we are intervening, when we are delivering, that there is a balance between maturity and loss of fetus. So that should be balanced, so that we will see it in the next slides. And at the end, that is the ductus venosus will reverse, and after that it's death, fetal death. But before that, there will be CTG and biophysical abnormalities. So late onset IUGR, as I said, it is not easy to diagnose because there is no associated placental disease. So placental reserve will up to the third trimester. Most of the time it manifests in third trimester only. So uterine TPA may be high in the cases of late onset IUGR also. That's why we are insisting on taking uterine artery Doppler in third trimester also. CPR may be less than 5th percentile, and MCAPA may be less than 5th percentile. Aortic isthmus may be abnormal, but look at the umbilical arteries. Umbilical arteries may not show anything in late onset IUGR. It's absolutely normal in many cases. So don't go with umbilical artery Doppler alone when we decide with IUGR, and particularly that's happening after 30 to 33 weeks of pregnancy. So suddenly may going for acidosis and acute deterioration in hours. It happens in hours, not in the weeks. That's like in early onset. So always deal carefully when you deal with late onset IUGR. So the crux is, if everything is fine but CPR is less, make close monitoring. Don't rush to the delivery, because many times MCA and CPR, everything has false positivity. So sometimes MCA may be abnormal, even in normal cases. Sometimes it may show low resistant flow. Based on that, if you decide we will induce prematurity. So it has to be, you have to repeat it. When everything is fine, MCA abnormal, then you have to repeat after 1 hour or 2 hours, even next day. Persistently abnormal, then look at all other things, then put a close monitoring, CTG, everything. And if it is, if more than 36 weeks or 37 weeks, then deliver better, because no need to wait with the risk of the unsuspecting late onset IUGR. But if it is 32 weeks, 33 weeks with close monitoring, we have to do, we have to go ahead up to 36 to 37 weeks. But sometimes the MCA becomes MCA you are seeing, and MCA is abnormal, and in repeat 1 or 2 days you repeat, it becomes normal, then you have to take it as if it's spurious or it's false positive. Then you can continue routinely. But we have to be careful when the late trimesters, the MCA and CPR is abnormal. We have to be should monitor closely in that cases. So always stage the Doppler, stage the fetal growth restriction based on Doppler. So stage 1 is either low fetal weight, that is less than 3 percentile, or mild placental resistance, that is CPR is less than 5th percentile, or uterine TPA more than, or MCA less than 5th percentile. It's all mild. Then we call it as stage 1. Stage 2 is absent end diastolic flow. And stage 3 is reversal of end diastolic flow in umbilical artery. Stage 4 is ductus venosus A-wave reversal. In that stage, CTG become abnormal. That is particularly the short-term variability. And follow up on timing of delivery in cases of early onset FGR. Stage 1, weekly monitoring up to 37 weeks. So 37 weeks you have to deliver better with labor induction and no need for cesarean as per guidelines. But in stage 2, that is absent in diastolic flow in umbilical artery, there is it indicates severe placental insufficiency. We have to monitor bi-weekly. That is up to 34 weeks only. So if it reaches 34 weeks, better deliver by cesarean section. You should not wait after that. But keep in mind, when you see the fetus at 32 weeks and showing absent end-diastolic flow, don't rush to delivery, because we are inducing prematurity, and the premature complications as well as FGR complications multiply for the neonate. So we can monitor closely, we can push up to 30 weeks, then deliver. So at the same time, hello, okay, for 5 minutes, for 5 minutes, okay. So low suspicion of acidosis, that is reversal of end-diastolic flow up to only it's allowed 30 weeks. If it crosses 30 weeks, you have to deliver. Up to 30 weeks, you can push it. And high suspicion of acidosis, that is rectus venosus reversal. If it crosses 26 weeks, better deliver. And it's not crosses 26 weeks, we can't do anything. We have to lose it. Most of the time, we cannot make the fetus survive. So we will see 1 or 2 cases because of short in the time is very short. So we will finish with this one case. This is a 25-year-old female, previous history of IUD at 20 weeks, obese, came for FTS at 12 weeks. The NT is fine, and urinary Doppler showing its high resistance flow. And we are doing combined screening in our setup. It's aneuploidy as well as preeclampsia. So the aneuploid is fine, and the preeclampsia, it shows high risk, and fetal growth restriction also it's showing high risk based on the FMF algorithm. So patient was started on low dose aspirin, and the follow-up scan at 20 weeks showing ACFL less than 10th percentile. See, and patient was as per our obstetrician, they sorted on low molecular weight heparin also, but in spite of that, at 26 weeks, the proteinuria was positive and BP was 140. The fetal growth was lagging. The Doppler umbilical artery showing high resistant, and MCA is fine. And uterine artery till the high resistance, as like first time. So look at the pattern of uterine artery. So these are the cases very high risk for complications. And at 28 weeks, this is the Doppler finding. That is high resistant flow in umbilical artery, again low resistant. This is stage 1 because only it's high resistant, not absent. But at the patient does not come or 1 week, it comes after 2 weeks, that is 30 weeks, severe oligo. Look at the umbilical artery, it's reversal of flow. It's MCA, it's fine, but diabetes is reversal, ductus fine. And so stage 3 IUGR, plan to immediate delivery by LSCS, delivered a male baby at 800 grams, kept in NICU for 45 days and improved to 1.5 kg and doing well. Thank you for the opportunity. And is there any questions?
No, sir, there's not much questions in the chat box. Thank you so much for your elaborate presentation, sir.
Yes.
There's just one question.
Yes, madam, please.
There is this baby which presents at 32 weeks. The weight of the baby is about, it's normal. It's about the 25th to 30th centile.
Okay.
But and the Dopplers, with regard to the Dopplers, the umbilical Doppler is at the 10th or 12th centile, and the MCA Doppler is also around the same, but the CPR is less than the 5th centile.
Yes,
so do we have to keep this baby under monitoring?
Yes, madam, because actually the late onset IUGR, we don't know anything what happens, what will happen, because up to 32 weeks, that everything is fine. Okay, everything is fine.
And the weight is also fine. So mostly when they get the report, they only see the weight, and if the weight is fine, they are happy and they reassure the patient. But when we see the graph,
weight will start lag after that. If really it is late onset IUGR. and we don't know
There is
that.
a
So
lag,
we have to keep
there
it
is
in,
a
keep it in
little
monitoring. That's enough. But if weight start lagging or Doppler changes start progressing, we have to make it as an IUGR fix.
After how many weeks do we have to call them, sir?
Till so if that means up to 36 weeks. Yeah, that is up to maturity.
Okay.
See,
So we call
don't-
them every 3 weeks for growth is enough, or for Doppler we have to call them every week?
every week when there is suspicion
Yes.
of late onset IUGR. So
There
late
is
onset
CPR
IUGR.
change alone.
Yes,
CPR
late
alone is
onset.
fallen, less than the
Follow-
5%.
Pardon, madam.
The cerebroplacental ratio is alone less than the 5th centile. Other Doppler parameters are not alarming.
Okay. This also that you that the weeks is weeks. At what weeks you are asking? Gestation age?
32 weeks. 32 weeks.
32 weeks scan. Okay. So we have to mention that in the report and pause for close follow. That's enough. And another thing, there are false positives we have to accept. The MCA may be falsely low and umbilical artery may be falsely high. There are conditions like fetal position or uterine contractions can cause all these things can happen in CPR, they reflect in CPR. So we have to repeat the Doppler once in the even with the same sitting, we have to repeat it after 1 or 2 hours. And if persistent, and you are sure that everything other things are fine until the persistently umbilical artery is showing something abnormal or MCA is showing abnormal, then we have to put it in because we have done some one study is undergoing in our center. This not only in our center, there are few centers associated with that, and we are doing Doppler in all pregnancies, and we are analyzing the outcomes. That's things with that. The scenarios as you are asking. So there are cases like umbilical arteries alone start showing high resistance, everything is fine. And CPR is showing abnormality, but persistently we have to the false positives you have to avoid in that cases. In that cases or end up in late onset IUGR, that's growth start lagging after that. 36 weeks, if you look, the biometry start lagging. Up to that 32 weeks, it was okay. But we have diagnosed some Doppler changes in third trimester, but it's not in all cases. But there are cases. So it is because you look at the prevalence. The late onset IUGR is more prevalent than the early onset. But do we diagnose late onset IUGRs? That means we are diagnosing only early onset IUGR. That means there is loopholes. So for that loophole, we have to take some extra care. That's it.
Okay, so after 37 weeks, Dopplers play a role, or is it more of a biophysical profile that
The Doppler play a role, madam, because if you compare studies, that is comparing biophysical profile as well as Doppler. So the changes, the fetal manifestations of hypoxia, whatever it is, it reflects best in Doppler. There the biophysical.
After 37 weeks, there is a physiological fall in the MCA-PIs, no, sir?
Yes. Yeah, that has to be taken into account. Then the percentage.
Along with both NSG
yes,
as
that
well as.
Even if you look at the nomogram chart, normal value itself will drop there. So you are going only with the nomogram. So you're not just absolute values.
That's all, sir. Thank you for the elaborate talk, sir. That's all the questions in the chat box.
Okay.
Next, we have one final talk. Shall we go to the next talk, sir?
Yes, madam. Please proceed, ma'am.
I'm happy to introduce Dr. Adi Narayana Makam. He is the president of SFM Karnataka chapter. He is the program director for fellowship training in fetal medicine at Adi Advanced Center for Fetal Care. He worked in the UK for 10 years and obtained his advanced training in fetal medicine at Cardiff. Before returning to India, he was the lead consultant in fetal medicine at Royal Gweri Hospital, Newport, UK from 2010 to 2012. He is a Rajiv Gandhi University Gold Medalist in MD OBG 2000. Special interest in fetal interventions, is an invited speaker in various national and international conferences. Over to you, sir.
Adi sir, can you start the presentation, sir?
Devraj sir has to stop screen share, sir.
Dr. Devraj, can you stop the screen sharing so that sir can start his presentation?
Yeah, I have stopped it.
Thank you, sir. Adi sir, you can share your screen, sir.
Just we are calling him, sir. Just wait, sir. We are calling him through phone. Sir, actually, his Zoom got disconnected. He's going to connect again, sir. Meanwhile, Madam can just ask few questions to Dr. Devraj.
Madam, you have to unmute yourself.
So there is not much of questions again, sir. So if the patient has a first trimester screening which shows a high risk for preeclampsia, say 1 in 75, but she comes to the obstetrician only at 20 weeks, is there any use of starting aspirin at that time?
Actually, that remodeling completes. Actually, the spiral artery remodeling completes. But when we discuss with the obstetricians with these things, but what they give the feedback is something is better than nothing. So we are starting. You are asking to start at 11 weeks, 12 weeks, continue up to 36 weeks. And if it is stops, everything remodeling stops at 16 weeks, why do you want to continue up to 36? You are asking to continue at 36 weeks. Then it's not started, at least we start at second trimester at 16 or 18 weeks. So from that feedback, we are till it's suggesting to start aspirin. What do you do in your practice, madam?
Yes, sir. We start, if there is a high risk for preeclampsia at 12 weeks scan, we start it immediately at 12 weeks itself.
Okay.
150.
Not started at 12 weeks. Will you start it in 20 weeks?
Well, like you said, it will definitely not be wrong to start it at 20 weeks. Given the risk, we have to explain to the patient that it would have been more effective if we started it early. But nevertheless, to start at 20 weeks also is not going to harm.
Yes, and
at least it will increase the blood flow.
Yes, another scenario, when the patient is in aspirin, the second trimester shows still a high risk. There is uterine artery notching, whatever it is. And in that cases, there is a thought that we'll add on low molecular heparin to the existing aspirin course. So is it useful?
And we add, if there is a previous history of a pregnancy loss or a previous history of a severe preeclampsia, or if there is a previous history of severe FGR and multiple recurrent pregnancy losses as such. So otherwise, with only a risk for preeclampsia, which comes in first trimester screening, FTS risk, we will only start her on aspirin.
Okay.
If there with a very strong history of a previous bad obstetric outcome, then a low molecular weight heparin, or if she's an APLA positive. If there is a strong suggestion with a report which definitely suggests that there is a high risk of thrombosis in this patient, then we start her on a low molecular weight heparin as well. Because all those conditions are also predisposing factors for preeclampsia as well.
And among the obstetric community, that dose of low dose aspirin is what is the situation?
We give 150 only, sir, as per the aspirate trial.
But
yeah, 150. But I have also seen prescriptions with 75.
Okay. Till many practices in the periphery continue to start with 75 milligram, particularly senior obstetricians. But it is not enough, isn't it?
Yes, sir. Because aspirate trial is one of the largest trials which is done for the prevention of preeclampsia, and that has proven to be 150. There are various studies which show that 100, 75,
yes.
all that is enough. But yes. Dr. Adi, sir, do we need to call him, sir?
Just a minute, I will call him.
Dr. Aishwarya, madam, you can also ask few more questions. So Sir is having some internet issues and he is trying to reconnect now. You can just proceed with few more questions. I think there are some questions from audience also. What is the difference between SGA and IUGR? Dr. Devraj, can you enlighten on this?
I think Sir is connected. So actually,
no, actually, he's trying to connect again. You can just proceed with few questions. I think few questions from audience side is also there. Yeah.
Somebody has asked, Dr. Karthikeyan has asked, what is the difference between a small for gestational age fetus and an FGR fetus? FGR fetus.
Small for gestational age, actually we take it as just less than 10%, but everything is fine. That maybe that growth potential is like that. So it's physiological. We take it as physiological. And in that case, again, we need to closely monitor. Because sometimes we call it as SGA fetus, but we monitor, and sometimes there may be Doppler change in the late. So better SGA means the Doppler is fine. You don't just leave it. You have to keep monitoring at least 2 weeks, once in 2 weeks, and look for Dopplers.
In SGA, they will not. The baby will grow in the same level on the growth chart from the beginning. No, sir. From when we are plotting the growth chart, that is why growth chart plays a very important role in differentiating an SGA and an FGR.
Definitely.
Yeah, Dr. Devraj, if you have any other short presentation, you can just maybe show few slides or images.
Okay. Just a minute.
I shared a small slide in the chat box, difference between FGR and SGA.
There is also one doctor who's asking if there is any prostaglandin blocker which can be used as a prophylactic in preeclampsia.
That you have to answer, madam.
No. There is no. There are some people who give sildenafil and all that in to prevent FGR, but I don't think it is only a placebo role. There is no confirmed role for sildenafil in the prevention or in the management of fetal growth restriction.
Yeah, Dr. Devraj, can you share some slides? A short presentation.
Yes.
Join.
Yes, I will start with just a minute.
One more.
And Dr. Devaraj, you can just proceed with any presentation.
I think Dr. Adi Mohan sir has
Achal, I
joined.
think you are ready.
You can
Okay, good, lovely. Thank you.
Welcome, sir. Yes, sir.
Can I start, madam?
Yes,
Yes,
sir. Please
sir.
proceed, sir. Yes.
And your introductory slides, sir. We welcome you, sir, for this presentation.
Lovely. Thank you, madam. Sorry for the technical glitch. I expected it's not always straightforward with the technology. No problem. Now I've got about half an hour to 40 minutes, I guess. First of all, I would like to thank you for including me or inviting me in this wonderful webinar. And Option Gynae for all general people is also required. And the previous speakers, Manigan Raj and Lakshmi Madam, wonderfully presented the pregnancy problems. Now, I have a Herculean task to present the placenta, liquor, and cord abnormalities. I don't know whether I'll do a justice for the next 30 minutes. That's why I've excluded so many, and I've included only absolutely necessary one. So I guess to include this topic is because we all will concentrate on the fetus and we may ignore the most important or the equally important organs like placenta, liquor, and umbilical cord. So today I'll take you through some of the placental and some of the liquor abnormalities. And cord abnormalities, there are so many, would warrant one more presentation on its own. So if possible, if time permits, I'll include them also. So first, we look at the placenta. Now, there are a lot of placental abnormalities. Again, I have not included all abnormalities. I'm going to present my case looking at placenta when we're going to worry. So that's the main crux of this presentation. So let's see. Now, all of you know the placenta is a wonderful interface, a fantastic organ, which is a hemochoroidal structure, which acts as a transport media from the mother to the developing fetus. So this did not get the proper attention and the respect what it deserves, because if you look at placenta, the placenta works like a cardiovascular system, providing the blood and working as a heart to the fetus. It works as a lungs. It takes away the carbon dioxide and gives oxygen to the fetus. It works as a GI system. It gives you nutrition to the fetus. Works as an excretory organ. All the metabolic waste, placenta will take it away. Also, it acts as an endocrine system. A lot of hormones are produced, and more than the physical protection, it can also give you chemical protection and immunological protection. from all the environmental dangers. So such a one organ which works as so many organs absolutely deserves a lot of interest, a lot of attention. So let's see how, if you assess somehow this placenta is working very well, we can predict the perinatal outcome. So if the placenta is looking well, working well, secreting and doing all the functions it has to do, then obviously the outcome of the baby is higher. So now, how do you assess the placenta? Placenta, you can look at the placenta by the ultrasound. It's called sonomorphology. You can do some biochemical assessments where we can assess the concentration of some chemicals in the mother. And as Devraj previously explained, we can look at the Dopplers. So looking at the Doppler studies, indirectly we assess how the placenta is working. So all these days, this Doppler has taken over the sonomorphology. In the past, when there was no Dopplers, we looked at the placenta and to see whether we get some meaningful, useful information. And after we got the Doppler, the sonomorphology has taken a backseat. Now, over a period of time, now we are revisiting the sonomorphology from the last few years. I mean, we were doing it before, but we are doing it a little bit more carefully. Now, when you look at the placenta should be in a proper place, and the length of the placenta more than the width or the depth of the placenta, and the cord should be inserted in the center, and it should have a normal Doppler. So if it has normal appearance, normal Dopplers, and a normal biochemistry, you expect the baby to grow appropriately very well. So now, what do we do about sonomorphology? So can we make some sense by looking at the placenta? So for me, the first thing which came to my mind when we were looking at placenta and making some clinical decision, it's like Ardhanarishwara. It may look very calm, but it can be very destructive. It may look very ferocious, but it may be very, very nice and healthy, happy baby. So by looking at placenta alone, we will not be able to tell whether this placenta is going to cause problem or not. You wish you make that distinction, but unfortunately not. I will show you a few cases. I'll show you a few cases where it really helps. And finally, what is our role in looking at placenta? So this is a day before yesterday's case, 36 weeks. If you look at this placenta, it looks horrific. It has got multiple calcified deposits throughout the placenta, both fetal surface and maternal surface. So you expect this placenta not working properly. But if you look at the Dopplers, that the surrogate marker, whether the placenta is working or not, the uterine artery Dopplers are extremely low resistance. That means this placenta is working beautifully indirectly. And also, if you look at the fetal Doppler also was beautiful. So placenta looked very voraciously abnormal, but all Dopplers were normal, and the baby was not even appropriate. Say, last for gestation, the estimated fetal weight was 3.8 kilos. So now, where is the placenta? Why we should worry about the placental appearance? You look at other things. I'll show you one more example. This is a doctor herself, a gynecologist. So she's a 31-weeker, and look at the placenta. Placenta looks nice and beautiful. No abnormal calcification except a few areas of calcification, which is expected at 31, 32 weeks. Nice long placenta, not thick placenta. And when you do the VCI, it gives you a little bit more appearance of the placenta, and you can assess the whole placenta in one screen, one go. And you expected no problem in this pregnancy, but if you look at the uterine arteries, it has got a high resistance and a notching. So that means placenta is not working very well and posing a lot of resistance. If you look at the Dopplers of the fetus were normal. Biometry was smaller. So this baby is estimated fetal weight is less than first centile. So the placenta looked completely normal, but if you look at the growth, the nutritional aspect of the fetus is extremely smaller. So now, looking at the placenta, we may not be able to judge whether this placenta is working very well or not. I think I've made a case. I'll show you some more examples. So this is another placenta, horrible looking placenta, because look at this placenta. The placenta is full of venous legs. So now, when the placenta, the half of the placental unit is filled up with non-gaseous exchange material of placental legs, you would expect some growth restriction. So when you look at the surrogate marker, that's the Dopplers were actually within normal limits. So I was surprised. I looked at the fetal Dopplers were also normal. But when you looked at the growth, the fetus was extremely small. So the estimated fetal weight is way below first centile. Okay, so I think it's playing. So way below the first centile. So the placenta looked horrible. Uterine arteries were normal. Fetal Dopplers were normal, but growth restriction. So this placenta is not actually supplying the nutrition to this fetus, and later on you may have more problems. This is another case. You can see the fibrin deposits in between the intervillous spaces. So a lot of fibrous deposits. So again, you expect this placenta not going to work properly. And you can look a little bit more detail. The vasculature, this is a fetal surface, this is a maternal surface. There are nice number of blood vessels are present. So sometimes the adding vasculature into equation may help you rather than just looking at the placenta. So here the uterine arteries are normal. So that means the placenta looks abnormal. The blood flow is normal. And the growth also was normal. So this, although the placenta looked abnormal, the growth is normal, the blood flows are normal. And this is another placenta. Again, the placenta looked completely normal, but uterine artery is normal. And growth is also abnormal. And you look at the fetal Doppler, there is an absent diastolic flow. So this is, the placenta did not look that bad, but uterine arteries were abnormal, growth is abnormal, and the fetal Dopplers are also abnormal. So by placenta, you would never expect this kind of an outcome. And look at the ductus venosus. Ductus venosus is also abnormal. This baby is severely hypoxemic and possibly acidemic. By looking at placenta, you would not have made any decision. So when I looked at the placenta with a little bit more technology, this is a volume contrast imaging. So in the volume contrast imaging, actually you can see there are a lot of malfunctioning, dysfunctioning placental appearance. So whether we can use this VCI to predict the outcome, we need a lot of data, and there will be a lot of overlap between normal and abnormal. So by looking at placenta, you can look at the placenta by different, its appearance, blood flow, VCI, whatever you did, you may not win. So this is one more case. You look at this placenta looked horrendous, horrible. So there was a cystic mass, and the placenta is discoid,
I think sir got disconnected. Please wait, there is some network issues. He's just coming back. Yes, there are some network issues. Sir is coming back. Just hold on, please.
Hello, am I audible now?
Yes,
Yes,
sir.
sir. You are audible, sir.
Okay, so now sorry again. What can I do? It's not in my hands. I will share it again. I think the power went at this slide, I think. So anyway, I'll go through a little bit of revision if necessary. So this placenta looked a little bit abnormal. So you expect the baby to be growth restricted, or it may be chromosomally abnormal, or maybe some other abnormalities possible. So when you looked at this fetus features, the growth was less because the femur was extremely small, and all, so with all the long bones. So this baby had a skeletal dysplasia. That means if the baby is not formed very well, the placenta also may not form very well. In other words, if you look at the placenta and placenta looks horrible, or placenta doesn't look normal, you may expect some fetal problem. So it is not completely ignorable. So this fetus we terminated because it was all long bones were shorter. The idea was you can look at the placenta. If the placenta is abnormal, baby may also be abnormal. So look at this case. This is a 21 weeker. Here there is a long sheet of fibrin deposit in the placental surface, in the fetal surface of the placenta. So you expect some gas exchange will be a problem in this kind of a placenta. That surprise, the uterine arteries looks completely normal. And you look at the vasculature, and the vasculature looks lovely. And the placenta appears normal. This is another case. Normal Dopplers and normal vasculature. So you don't expect any problem in this fetus. But when you look at the VCI, you can see a lot of placenta has got a solid elements. So that means it may not be working very well, although it may look normal and the Dopplers are normal. But look at the fetal Dopplers. The umbilical artery has got an extremely high resistance flow. So sometimes the 3D will help. So this is another case where you can see the look of the placenta. Placenta has got a lot of lacunae. But growth is lovely. You expect a IUGR fetus with this kind of a placenta, but the fetus is completely normal. I think I made my case about looking at the placenta and being abnormal or not. So look at this placenta. So this is the length of the placenta is very, very small. The depth of the placenta is more than usual. That means it's a discoid placenta or a short and stubby placenta. So now I said placental appearance may not make a difference, but a placenta like this makes a huge difference. Why? I'll show you. This is called hyperinflated placenta. And when you look at the umbilical artery Doppler in this case, it's severely abnormal. At 23 weeks, almost absent diastolic. So I remember this quote, Akara Pusti Naivedyam Nasti. That means the placenta looks so big, but actually it is not working very well. Why? So if you look at the placenta, a thin, long placenta will have a lot of the surface area for gas exchange. On the other hand, if it becomes short and stubby, the gas exchange may not happen. That's a hyperinflated placenta. So the idea is, this is I got it from Mani sir. So is based on the chorionic regression. If you look at the endometrial surface, the developing embryo comes and embeds, and cytotrophlus and cytotrophlus makes its way into the decidalized endometrium and forms a placenta, and the rest of the area will leave this chorionic levi. So this will not be functional. Only this portion will function as a placenta. Now, if you have excessive chorionic regression, that means most of the chorionic levi leaves and the available placenta will be very short and stubby. So this is called hyperinflated placenta. If it becomes asymmetrical regression, the cord will be inserted into at one edge of the placenta. Okay, so I don't think I need to go into the basics, but if you look at the placenta, decidalized placenta, and the chorionic villi will make its way and erodes all the spiral arteries and makes this beautiful gas exchange unit. So this is called anchoring villi. If the anchoring villi are less, this is where all the gaseous exchange will happen. If the anchoring villi are less, number of villi participating in gas exchange will be less. So you expect growth restriction and hypoxia. So you expect suboptimal perinatal outcome if the placenta is short and stubby. So if you look at the, this is a 2008 data. If you look at the placenta, if the placenta looks normal, the perinatal outcome is bad in only 12.5. But if the placenta looks abnormal, the perinatal mortality is higher. And also the growth restriction is higher. So looking at placenta and hyperinflated placenta in particular may have some value. Okay, I don't think I need to go through that one. Right, so that's about placental appearance. The other important problem of placenta is if the placenta is implanted in the lower segment, especially in the previous cesarean section scar, it may be adherent. So this is called placenta accreta spectrum. So this placenta accreta spectrum itself is about half an hour lecture. I had several cases. I've taken it out. So I've shown you one case where the typical appearance, loss of hypoechoic zone between the placenta and the myometrium. In this case, there is no myometrium. This is the bladder interface. There are a lot of bridging vessels and a lot of lacunae. This is a morbidly adherent placenta, or we should not use morbidly adherent placenta. We should say it is placenta accreta spectrum. And this requires a lot of attention. Then it requires a multidisciplinary team to manage. Okay, so the other problem placenta can have is grape-like structures inside the placenta that is called hydatiform mole. So it can be complete mole, it can be partial mole. Complete mole, again, it's a different spectrum on itself. Now, this case I've shown you is a 13-weeker. The placenta has got a lot of grape-like structures and the fetus was abnormal. In this case, the baby had a hypoplastic left heart syndrome. So this is likely to be a partial mole, where partial mole, the fetus will be formed, but it will be usually abnormal. So this is another case at 21 weeks, 6 days. Look at this placenta. This placenta looks abnormal with a lot of grape-like structures, and the stroma was looking abnormal. So this is part of the placenta was looking okay, and part was abnormal. This is distinctly different. So if you are not in the habit of looking at the placenta, you may overlook this one, because when you see it like this, you may assume that it is normal and you don't do anything. So this is a placental mesenchymal dysplasia. I think the videos are not playing. I don't know why. And it has got a lot of vasculature, hypervascular structure. This is another case. Oops, looks scary. So this whole of the placenta is full of, I'm sure you would not miss a case like this, but look at the part of the placenta was normal, part of the placenta was abnormal. And when you look at the vessel, less amount of vasculature. So if you have hypervascularity, then it's a molar. If there is less vascular, it can be placental mesenchymal dysplasia. So this is another case where one of the twins had molar changes, so it can coexist. Another problem we can face is the tumors of the placenta. The tumors of the placenta, the only tumor of the placenta is chorioangioma. I'll show you one case and I'll show you how did we manage that one. So if you look at this placenta, there is a distinct mass. Huge mass. So when you put the color, these are the chorioangiomas, are the tumors which usually present next to the cord insertion. This is a cord insertion and a huge placental mass. That's a chorioangioma. You see, this is the cord insertion. Next to the cord insertion, you see a mass, which is exophytic. Sometimes they are not exophytic. Sometimes they are not vascular also. So that's why we will not be able to detect all chorioangiomas in all the time. So if you put the color, it is highly vascular. And as I said, it looks very scary. So this is a 25-weeker. And when you do the Doppler assessment, this fetus was anemic as well. The MCA Vmax was high. So the chorioangiomas not only cause cardiac strain, it also causes thrombocytopenia, thrombocytopenia, and also consumption hemoglobin sequestration into the tumor mass that reduces the effective hemoglobin mass in the circulation. So baby will be anemic. So you look at the heart was globular. There was evidence of cardiac strain was there already. So you can do something called heart quantification, where it's a spectral Doppler. You look at how the endocardial movement and indirectly assess how the heart is squeezing. And there was evidence of cardiac strain. And management option, because it's anemic, would you do both procedures of laser or radiofrequency ablation of the tumor or the intrauterine transfusion or together? So this was a lot of dilemmas, and the patient agreed, came back for treatment, and at that time findings were worsening. And then we decided to do the laser first, interstitial laser, and kill the tumor. And afterwards, if she's still pregnant, we'll do intrauterine transfusion. So because we did not want to do both procedures at the same time, and patient was also not very willing to do the procedure. So she agreed for one treatment, and then we did the laser. So laser, it's not that difficult. We got to be careful, and we may have to take this laser at several points of the feeding vessels, and then we have to burn. And it's a straightforward 18 gauge needle, and then you can pass a laser cable and go next to the blood vessels and burn the vessels. You can do radio frequency. You can do glues as well. Mani has done one glue, and I've done only one glue. I don't know, Mani has done more than one, but I've done only one glue. I feel laser or radio frequency is much easier and much nicer. So we burn the tumor, and as soon as we burn the tumor, look at what happened to the vasculature. It was very scary before the procedure, and after we burned, it's almost become avascular. so cardiac functions improve. And then we did transfusion, intrauterine transfusion. I don't think I have time to show the blood transfusion. Straightforward procedure. Then MCA came down. Then tumor was less. So the cardiac function getting better. And then 2 weeks later, we did give one more transfusion. And then we took her to term, and cardiac function did very well. And then she delivered a 36-weeker. This is one more case of a small chorioangioma, but it was causing a lot of polyhydramnias. And we did a radio frequency ablation, straightforward radio frequency. You can see this is a radio frequency needle. You open up the fangs and then you burn the tumor. This is a radio frequency needle. And you pass the radio frequency energy. So slowly the tumor gets burnt. Okay, so I think I spoke too much. Now, we were doing Dopplers. We're also looking at the blood levels. Now we should look at the morphology as well. So now what I want to end my placental talk is by we got to be little smarter. Our opinion swings from one side to the other. In the past, when we didn't have adequate technology and Dopplers, we looked at the placenta very carefully and we graded the placenta into several. And based on this one, we thought whether it's a risk for IgGR and all those things. And because it was very crude method and we certainly failed several times. And then once the Doppler came into action and we conveniently forgot how the placenta looks and we turned a blind eye into the placenta. So now what we should do at this age, something called smart look. You should know when to look, how much to look, and what do you make out of looking at a placenta. Don't make your entire decision looking at the placenta. You have to take several things into account and make a decision. So that's my placental talk. And if I have time, I'll go to the Liker or I'll take some questions. Hello.
Are there any questions?
How much time do I have?
Sir,
Yeah,
you
another-
can continue 10 more minutes, sir.
10 more minutes you can
Right.
continue.
Yeah, 10 more minutes is too small a time, but that's okay. I will take you through the Liker abnormalities, few cases. So amniotic fluid production is entirely different before 8 weeks and after 8 weeks. Before 8 weeks is mainly because of the hydrostatic and osmotic. The amniotic fluid is secreted in the amniotic cavity. Later on, a lot of things happen. By 8 weeks, urethra is open. Your kidney starts to make urine, but not sufficient enough until 14 to 16 weeks. And after 16 weeks, most of the amniotic fluid is by the urine production, and baby starts to have keratinization of the skin. Before 18 weeks, the skin also perfuses a little bit into the amniotic fluid, but that because of the skin keratinization, that transfusion from the skin will reduce, and the keratinization is complete by 25 weeks. So this we need to understand, and that's why the Liker volume is different in different gestation. It is not linear relationship. At 20 weeks, 200 mils. At 28 weeks, 800 mils. but at 42 weeks is significantly less, 400 mils, and around 10 weeks is about 25 mils. So if you look at the dynamics of the LICA, so many organs or so many structures will produce LICA, and so many will absorb the LICA. So overall, the fluid dynamics is maintained, and I don't think I need to go into the details how much each. This is for some other day. The amniotic fluid is considered as amruta. It not only protects the fetus from physical insults, it also has got several functions, nutritive functions, growth factors. There are erythropoietin and tropical growth factors. So many functions are there. It acts as an antimicrobial, but sometimes the LICA can be harmful. Where in open neural tube defects, the neuronal tissue exposed to amniotic fluid can have chemical injury. In gastroschisis, the bowel which is there in the amniotic cavity, the amniotic fluid can irritate the bowel.
Sir, your PowerPoint is not seen, sir.
The PowerPoint is not showing? Oh dear. Okay, I will share again. Is it visible now?
No, sir.
Why is that? So sharing. Your sharing has failed to start. The window you selected is invalid. Okay. Hello. Is it visible now?
Visible, sir, visible.
Visible. Oh my God. Thank you. Okay, the next question is how do we assess? We can assess qualitatively and we can assess quantitatively. So qualitative assessment is not sufficient. You need to do quantitative assessment. And also you need to look at whether the LICA is clear or not. First, I'll show you how do you assess the echogenicity and what is the importance. Usually the LICA is clear, but sometimes it is echogenic. If it is echogenic, it can be due to normal, vernix, fetal squamma, meconium, and intraamniotic bleeds. and sometimes excessive desquamation conditions like hypertrichosis or epidermolysis bullosa. So the excessive fetal desquamation conditions or ichthyosis, harlequin ichthyosis is one condition. Another condition is junctional epidermolysis bullosa. So this is not my video. So this is the horrible condition. This excessive desquamation of the skin causes the lichen to be very echogenic. Other reason is epidermolysis bullosa. I'll tell you something about that later. So now, how do you assess the quantitatively? That is, how much fluid is there? How do we assess? We can look at amniotic fluid volume, and we can also do some biochemical assessment in amniotic fluid. So amniotic fluid assessment, the only way to know how much is amniotic fluid is the closest and effective method is the dye dilution technique, but it is not used in clinical practice. It is only experimental, because if you have to inject the dye and dilute the dye and see how much of the amniotic fluid, it is actually not practically possible to make your clinical decisions. So what you can do is an ultrasound examination, what is called amniotic fluid index. You divide the uterus into 4 equal quadrants and keep your probe vertically and measure the deepest vertical pool of the 4 quadrants, and you add up. So if you don't do it properly, you will get whatever assessment you want, and you plot it on the graph. And if you don't have a graph, rough 8 is your lower limit, 24 is your upper limit, and anything in between is normal. Above 24 is polyhydramnios, below 8 is oligohydramnios. And again, you use the amniotic fluid index. Whether you do amniotic fluid index or a single vertical pool, it practically does not make any changes. Practically doesn't make any difference. So you may want to do only single depressed vertical pool, but many people ask for amniotic fluid index. So we are in the habit of doing amniotic fluid index. So when you measure the amniotic fluid, you also have to make sure that there is no cord or the fetal parts. Anyway, you don't exclude the fetal parts, but you also have to exclude the umbilical cord. Or if there is, if you can't exclude, you have to have 1 centimeter away from the cord, and then see whether AFI or single depressed vertical pool. For all practical purposes, even in a randomized control trial, single depressed vertical pool did actually fared very well. And also using AFI, sometimes the intervention is high, because sometimes you assess a little bit less and then cause more of heartaches. So you don't, single depressed vertical pool is equally effective or probably better than amniotic fluid index. So when do you call it oligohydramnios? When the amniotic fluid is less than 5 or single depressed vertical pool less than 2 centimeters. What are the causes? Obviously, rupture of membranes is your main cause. Otherwise, malfunction of the kidneys or renal agenesis, and obstruction to the outflow of the urine, and there are miscellaneous. So I don't want to go into the detail because lack of time. Rupture of membranes, you got to be careful. Chorioamnionitis is going to be a big problem. And renal agenesis, obviously you may need color to make a diagnosis. Luto is a difficult condition to manage, and most of the time they are unexplained. If they are unexplained, what do? Will you give any medication like L-arginine, or will you give amnio infusion? Both of them do not have any evidence. So there are a lot of data available to say that L-arginine may be a little bit useful. I think it is useful psychologically rather than anything. If you don't give anything, patients will go to some other doctor. On the other hand, if you give something, they think that there is being treated. So basically, the amniotic fluid on its own does not make a huge difference. Of course, if it is too severe oligohydramnias, then it's got a complications of its own. So would you give amnio infusion? So there is no absolute role of doing amnio infusion in modern fetal medicine because of a lot of complications associated with, and also it will not stay for longer. So polyhydramnios is 24. Now, when you get a polyhydramnios, you look at the fetus. If the fetus is large and the water is more, it's a good combination. If you have a small fetus and oligohydramnios, it may be explainable. If you have a small fetus and polyhydramnios, this is a wrong combination. So if you get polyhydramnios and if the fetus is big, you're good. If the fetus is small, then you need to think that this baby is not doing very well. It's not just idiopathic. So there are several causes. Most likely it is unexplained and sometimes is due to gestational diabetes and rarely due to some conditions like Bartter syndrome. So this is not that rare. I was thinking it's only in textbooks. I have seen 4 cases in the last 7 years. So you got to be aware. You got to be aware of the condition called Bartter syndrome. And would you give any oral medication to reduce the liquor in an unexplained, or will you do an amnio drainage? There is no role for oral medication because it causes ductal constriction. But if you are far away from the term, you may want to use indomethacin or Solindac and also newer medications available, not very useful. And would you do amnio drainage? You do only if there is severe maternal discomfort, or if the cervix is opening up, or umbilical artery showing abnormality. Because if you imagine severe polyhydramnias, the umbilical cord has got inherent tension and the blood flowing in the umbilical arteries may be lower velocity, and sometimes it becomes absent in diastolic flow, diastolic phase. So if all these conditions, if any of these conditions, then you put a needle and drain the liquor. Otherwise, there is no role for doing a routine amnio drainage. So I think this is a last slide. I want you to watch this one. I'll stop. This is a severe polyhydramnias with a lot of maternal discomfort. So we put in an 18 gauge needle. Look at this fetus. It brings its hand, extends its index finger, and touches the sharp end of the needle and takes it away. I'll watch it again. So look at this. This is the eye looking at the needle, brings the hand. This is the index finger. It's touching the needle and moving away. Amazing. After watching this one, my belief on Mahabharata is increasing. Unbelievable. Up? Okay, good. Thank you very much. I think I'll stop here.
Thank you so much, sir, for the elaborate presentation and the beautiful images and videos.
Thank you, madam.
Thank you so much, sir. It's a pleasure to watch. I don't think there's any question in the Q&A, sir. If there's there's no question in the chat box because it was a very clear presentation. Everyone was just drumstruck with the videos.
No, madam. I wish I had more time. There you go.
Thank you so much.
Thank you, madam. Thanks very much for your all patient hearing. Sorry for all the technical glitches. Not intentional. Unfortunately.
Yes, sir. It was there throughout.
Right.
It
Good.
was there. Even before that, it was there, sir. There's some. I think it's because it's a prolonged meeting that it is bound to happen.
All right. Okay.
Over to you, sir.
That was an amazing presentation, sir. As
Thank you,
usual,
sir.
you rocked, sir. You rocked.
Sorry, sir.
Adi sir is actually a one-day international slog over hitter. Now he had made as a T20 slog over hitter. You finished 2 topics in the stipulated time, sir. Thank you so much, sir.
Thank you, sir. Thank you very much.
So that brings us to the end of the session for today.
Lovely.
Any questions? I don't see any questions in the chat box. Yeah, there's one question, sir. How to differentiate placental mesenchymal dysplasia from DCDA with 1 molar twin?
With difficulty. So molar and placental mesenchymal dysplasia appear similar. The one of the distinguishing feature is the vascularity. And another is I forget the name. Beta SCG, sorry. Beta SCG. In molar pregnancy, beta SCGs are extremely high. Whereas in placental mesenchymal dysplasia, the beta SCG is not very high. So vascularity and the biochemical assessment together. And also you need to get a biopsy for a final conclusion that is only possible postnatally. And both placental mesenchymal dysplasia and molar pregnancy may have fetal abnormalities. So you need to do underlying chromosomal single gene disorders in both cases. And if it is a DCDA, one sac is molar, the outcome with a live baby is also difficult. Whether you make a diagnosis of a placental mesenchymal dysplasia or a molar pregnancy, the outcome is very bad in that pregnancy.
Thank you, sir. Thank you. So, no other questions for you. As everybody told, it's a clear presentation, sir. Wonderful, amazing presentation. So, so it gives me an immense pleasure to give the vote of thanks for today's session. I thank the CGP IMA Tamil Nadu State Branch team for organizing such a wonderful webinar. I thank our immediate presidents, Dr. Sengatuan sir and Dr. Sridhar sir, for sparing their time in the initial stages and allowing us. I thank our treasurer, Gauri Shankar sir, for giving the introduction talk. I thank Dr. Sendil for welcoming the audience. Especially all the speakers were excellent today. I thank all the speakers, Dr. Devarajan sir, Dr. Lakshmi madam, Dr. Adi Narayan sir. Everybody were so excellent in their presentations. And I thank Dr. Aishwarya for coordinating wonderfully with the speakers and the audience. I thank everyone, all the doctors who have spared their time throughout the evening and discussed, actively participated in the CME and the webinar. I thank one and all for the patient listening. Thank you. Thank you. Let's see tomorrow for the third day of this continuous webinar program. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye, sir.
Thank you, madam.
Sir.
Thank
you,
you,
madam. Madam. Adi, sir. It was excellent,
Thank
sir. I think it's one of the extended version. This is the longest theme which we had so far. Almost 3.5 hours. Thank you so much, sir. And the audience also for the patient listening. Yes, sir.
Thank you, sir. Bye-bye.
Thank you, madam. Thank you, sir.
Bye-bye.
Sir, thank you, sir. Yes.
Thank you, sir. Thank you.